Hello, Dr. Jaskar and one, we are live. Over to you.
Yeah. Good afternoon, everyone. It is my pleasure to welcome you all today to the Ped-Rtcon webinar, which has been conceived collectively by the Pediatric Oncology Group at Rajiv Gandhi Cancer Institute, with the help from Department of Radiation Oncology, Pediatric Medical Oncology, and Pediatric Surgical Oncology. And this webinar we are organizing to commemorate the 25th anniversary of our hospital's foundation. And we are very grateful to the Association of Radiation Oncologists of India, who have given us their consent to be a partner with our hospital to organize this webinar. Dr. Vishisht, the president of our association, has always been very helpful in organizing academic events, and I'm very grateful that he has supported our event also. I would like Dr. Vishisht to just give us his thoughts for inaugurating this webinar, sir.
Good afternoon, everybody. First of all, my colleague, particularly Dr. Siddharth Laskar and other colleagues. And first of all, I congratulate to Rajiv Gandhi Cancer Institute for celebrating a 25th anniversary and wishing for Rajiv Gandhi Cancer, they will progress more and more. So that we found one institute in North also that is good in doing everything in cancer management. Now, for this conference, it is very good for the PG students who are going to appear for their exam. Because I have seen the whole data, the whole scientific program, that is very good and very well arranged and cover the every part in the pediatric malignancy. Those are coming the routine practice and examination also. So, and at the same time, it is also good for others also, seniors also, to learn the pediatric, because we don't find something in the more in the literature also, in the pediatrics also. And hoping after this conference, all will go with good learning and practicing their juniors, their in clinical practice and in the examination also. Bad period for everybody, in particular doctors, and due to protecting all of us and enforcing our knowledge. All the best to all. Thank you.
Thank you, sir. As everyone has received the scientific program, we will be covering three topics today: Hodgkin's lymphoma, rhabdomyosarcoma, and Ewing sarcoma. The scientific session is based on a lecture by an eminent faculty, followed by a panel discussion being moderated by another eminent person of the specialty, and discussing the cases with the panelists. We will take questions in the chat box. So kindly post your questions in the chat box, and people who post their questions in the chat box would receive a certificate first. I therefore request everyone to be interactive in the chat box. We will try to answer as many questions as possible. Now, without taking much time, I would like to invite the chairpersons for the first session. I would actually hand over the proceedings to Dr. Sarthak. Dr. Sarthak, you can go ahead, please.
Yeah, thank you, sir. Good afternoon, everyone. I hope everyone is safe, especially during this pandemic. And I am Dr. Sarthak, coordinating session 1, which is on Hodgkin's lymphoma. And without taking a lot of time, I would like to introduce our esteemed chairpersons who will be chairing this session. And I would like to invite Dr. Gauri. She is Medical Director, RGCI Niti Bagh, and Director, Pediatric Hematology and Oncology in New Delhi. Also, I would like to invite Dr. Lalit. He is a Senior Consultant, Medical and Pediatric Oncologist at Mahatma Gandhi University of Medical Sciences Technology, Jaipur. I hope both have joined. For the first session, we'll have Dr. Sandeep Jain. He will be giving a talk on optimizing therapy in advanced Hodgkin's lymphoma. Sir is a Senior Consultant in Pediatric Hematology Oncology in RGCI New Delhi. Sir, I would like to hand over the mic to you, and probably if you can start with the talk.
Just 1 minute. Can I just say hello to everyone? I'm the chairperson for this session. I'm Gauri Kapoor. And I just want to say that we are really delighted that Dr. Vashisht has given us this pleasure to host this pediatric solid tumor CME or update along with our radiation colleagues, Dr. Jaskaran and Dr. Anjali. And I hope that all our fellows and PGs will find a lot of pearls of wisdom and many practical points in today's 3 sessions on Hodgkin's, rhabdomyosarcoma, and Ewing's. I also greet my co-chairperson, Dr. Lalit. Are you here, Dr. Lalit? Hello, Dr. Lalit.
Dr. Lalit has not joined still.
Okay, so in that case, I'll request Dr. Sandeep Jain to deliver his talk on Hodgkin's lymphoma. And I think he will speak on advanced Hodgkin's lymphoma.
Okay, thank you, ma'am. Can you see my slides and hear me well?
Yes, sir, we can.
Okay. Good afternoon, everyone. And at the outset, I'm really thankful to Dr. Jaskar and Dr. Anjali for organizing this webinar, which is a collaborative webinar with pediatric and radiation oncologist. And it is not very often that we see this kind of webinar, and I'm hopeful this is going to be a very good learning experience for all of us. So I have been assigned to speak on optimizing therapy in advanced Hodgkin lymphoma. So we all know that Hodgkin lymphoma is one of the most curable malignancy, not only in children, but also in the adult population. With the current multi-modality treatment, the outcome of advanced stage Hodgkin lymphoma is around 80 to 90%. We all know that chemotherapy and radiotherapy are quite effective modality in Hodgkin lymphoma, but at the same time, we have to be mindful of the late effects associated with these modalities. And so there's a need to maintain a delicate balance between these two modalities so as to maintain a impressive event-free survival and also not to induce too many late toxicities. With this background, I shall be covering today's topic under the following headings: definition of advanced stage Hodgkin lymphoma, what are the chemotherapy options that we have, what is the role of radiotherapy, what are the lessons that we have learned from our recently concluded INPOC Hodgkin lymphoma study, and what is the way forward. So let's start with the definition of advanced stage Hodgkin lymphoma. So the definition of advanced stage is quite variable among different research groups, and even it varies within the different studies by the same group. So like Children Oncology Group COG defines advanced stage as 3B and 4B, while the European group defines it as 2B, 3A with extranodal involvement and 3B and stage 4, while Pediatric Hodgkin Consortium defines it as 2B, 3B, and stage 4. Most of the Indian studies define it from 2B to 4 or stage 3 and 4. So why is it important to know about the definition of advanced stage? Because if we have to critically analyze any paper or we want to compare two studies, we need to have a common denominator for meaningful interpretation. And that is only possible when we know the targeted populations. For example, if we have to compare COG study with Euronote for advanced stage, we cannot compare it directly because the denominator is not the same. So it is very important to know what we are dealing with and how this is interpreted. So now let's come to the chemotherapy options in the Hodgkin lymphoma. So we know that the chemotherapy forms the backbone of Hodgkin lymphoma treatment, and combination chemotherapy is preferred over single agent drugs. The drugs which are effective as a single agent and that prevent the development of cross resistance and those with the non-overlapping systemic toxicity are generally combined together to form a protocol. All the protocols generally recommend 4 to 6 cycles of chemotherapy, and the interim assessment is done after 2 cycles. Treatment is generally risk adapted. By risk adapted, we mean that the treatment is not just based on the stage of the disease, but we take into account bulk of the disease, involvement of extranodal sites also for decision making. And it is response based. By response based means that after 2 cycles of chemotherapy, if there is suboptimal response, we can intensify our treatment. So now let's look what are the active agents of chemotherapy in Hodgkin lymphoma. So active agents are vinca alkaloids like vincristine, vinblastine, prednisolone, anthracycline like doxorubicin, alkylating agent like procarbazine, dacarbazine or cyclophosphamide, bleomycin and etoposide. So some of these agents are actually combined together in such a way that they have some synergistic action and then a regime is made. But we have to understand that all these agents are also associated with some late toxicity. Like anthracyclines are associated with cardiomyopathy, alkylating agents may be associated with sterility in young children, bleomycin may be associated with pulmonary fibrosis, and etoposide may be associated with the secondary leukemia in small number of patients. So whenever a protocol is designed, it is done in such a way that we have a check on the cumulative dose of all these agents so that an EFS which is desirable is also achieved without inducing too much of the late effect which may affect the quality of survivors. So now let's look at the common protocol that are being used in the pediatric population. In fact, the biology of the pediatric Hodgkin lymphoma is almost same as that of adult population. However, because of the elevated risk of the late effects when they are given at a younger age, it has led to development of pediatric specific protocols. Like SDS, which includes St. Jude, Dana-Farber and Stanford group, they give 3 cycle of VAMP and 3 cycle of COP chemotherapy. The POG now, it's called COG, actually give 3 cycles of ABVPC for rapid early responder and 5 cycles for slow responder. Euronet gives 2 cycles of OIPA followed by 4 cycles of COPDEC, and most of the Indian studies give 6 cycles of ABVD for advanced stage Hodgkin lymphoma. So now let's look at the outcome with these different regimes. If we see here event-free survival, it is close to 80 to 90% for most of these and overall survival is in mid-90s. So if we look at more intensive regimes like Euronet protocol or ABVPC, the event-free survival is 7 to 8% higher than the lesser intensive treatment like ABVD. But we have to see what kind of infrastructure, supportive care infrastructure we have, how much toxicity we can handle, and accordingly we have to choose our protocol. The important thing that we have to ensure that not even a single patient we should lose because of acute toxicity in Hodgkin lymphoma, and accordingly choose the protocol that we can deliver safely. So what are the different lessons that we have learned from the experience of this trial over a period of time? So we have understood that alkylating agent and anthracycline are integral component of treatment. And if we reduce their dose drastically, it adversely affects the event-free survival. With the North American POG group, we have learned that for rapid early responder, 3 cycles of ABV-PC with involved field radiotherapy is sufficient, while for slow responder, 5 cycles are required. With the German group, we have learned total replacement of procarbazine with etoposide is not possible and it reduces event-free survival. With the recently concluded their C1 study, they have shown that COPE can be equally effective as COPDEC, and COPDEC is less gonadotoxic. In India, what we have been doing conventionally, we are giving 6 cycles of ABVD, and it has worked reasonably well for most of us, and no major modifications have occurred in last 2 decades. So with all these regimes, we have been able to achieve an event-free survival of 80 to 90%. So the next question is, can we improve on this event-free survival further? The answer to this lies in the immunotherapy. In fact, in today's era, there's no discussion is complete if we don't talk about the immunotherapy. And this is a study which was published in the JCO last year by North American group, where within OEPA COPDEC backbone, actually every dose of vincristine was replaced by brentuximab, and radiation was only given to the nodes which were not in complete remission after 2 cycles of chemotherapy. And they treated 77 patients this, and they achieved a remarkably impressive event-free survival of 97.4. And there was substantial decrease in number of patients who received RT, and the field of RT was quite diminished. So I think this kind of survival was not achieved ever before for advanced stage lymphoma. Of, or can we also some therapeutic which are associated with the late effect? Currently addressed in the ongoing COG trial, 1331. The one is receiving actually their therapy, which is ABVPC, and in the other arm, actually, they have replaced bleomycin with the brentuximab. The result of this trial is available and will be available soon. We all know that the stage pediatric Hodgkin lymphoma number are always not there to answer a scientific question. So to overcome that barrier, the COG group has actually joined hand with their adult counterpart, and they are recruiting patients more than 12 years of age with up to 60 years of age to receive nivolumab or brentuximab with AVD chemotherapy in newly diagnosed high-risk Hodgkin lymphoma. And one more modification they have done in the protocol, and they are administering ISRT to the patient who positive that we do today, at least in the developed country where brentuximab and other immunotherapy is available. I totally agree that in developing country, availability and affordability still poses a challenge. I think in times to come, this gap is going to narrow down. So let's now see about the role of radiotherapy in advanced stage Hodgkin lymphoma. We all know that Hodgkin lymphoma is highly radiosensitive. Historically, all patients with advanced stage Hodgkin lymphoma receive radiotherapy. However, because of the late effect associated with radiotherapy when they are exposed to young children, the indication, dose, and field of radiotherapy have evolved 2 decades. And let's look at these 3 aspects in more details now. Let's start with the dose of radiotherapy. Again, historically, all the patients, those who were eligible for it, used to receive 36 to 45 gray of RT. With designed and cooperative trials, we learned that this high dose of radiotherapy is not required, and 30 gray of radiotherapy is sufficient. Another thing that we have learned over a period of time is that we can titrate dose of radiotherapy according to response. For the nodes which are in complete 30 gray is sufficient, and for the nodes which are in partial remission, 30 gray radiotherapy is recommended. In Euronet, they have an additional parameter of residual volume. For that positive node, they give 19.8 gray. If the tumor volume is interim assessment is an important determinant for deciding the doses of radiotherapy. Now, let's come to the field of radiotherapy. Again, historically, we used to irradiate large fields like mantle field, inverted Y, or extended field. But this is obsolete now, and nobody does this kind of irradiate. Nobody irradiate these kind of fields now. Till recently, involved field radiotherapy was like standard of care, where the involved node and the adjacent area on the ipsilateral side was given radiation. But the current standard of care is just the involved or targeted node that we irradiate. So with better radiotherapy techniques and improvement in the modality of imaging, we have been able to reduce the dose and field of radiotherapy quite significantly. Now let's see the indication of radiotherapy. Again, North American group conventionally used to give radiation to all patients of advanced stage Hodgkin lymphoma, irrespective of the response. The first trial actually which tried to omit radiotherapy in advanced stage Hodgkin lymphoma for good responder was German HD95 trial. However, what they found that the patient who had complete response and who did not get radiotherapy had much inferior survival, 69%, compared to patient who were partial responder but received the involved field radiotherapy, and their outcome was significantly better in the 90s. So it was clearly established from that trial that the response cannot be the sole criteria for defining the indication of radiotherapy. And we need to correctly identify the patients who can be actually benefited by omission of radiotherapy without affecting the event-free survival. And this they could in the last trial, which was published in the Lancet last month only. And here 1365 patients of advanced stage Hodgkin lymphoma were treated with 2 cycles of OIPA, and they were given either 4 cycle of COPE or 4 cycle of COPE-TEC. Here, they identified rapid early responders after 2 cycles of chemotherapy by seeing metabolic response in Ped-Rtcon, and Dewey score of 1 and 2 was considered as complete metabolic response. And those who achieved this kind of response, RT was omitted for this patient. And second randomization was to compare if COPE-TEC and COPE are comparable. So now if we look at this graph, this is the event-free survival of the patient who received or who did not receive radiotherapy. And we can see that the curves are almost superimposable. So they could correctly identify the omission of RT in a certain subset of patient. Then if we look at the second randomization, and here also again the curves are quite superimposable, and they could show that the high dose procarbazine can be replaced with the low dose dacarbazine, which is much less gonadotoxic. Now the important question is, now can we extrapolate these results to our setting, and can we try to see if we can omit RT in our patients? The answer is these results cannot be and should not be generalized, because they have used a very intensive chemotherapy like OIPA and COPE-TEC, unlike in our setting where we use ABVD. In fact, authors have themselves concluded that 2 cycles of OIPA is almost equivalent to 3 cycles of ABVD. Then they have done a central review of all the PET scan, not only during staging, but also during the interim assessment. Then the third thing is they had taken a complete metabolic response as Dewey score 1 or 2, unlike in most of the study where they are taking as Dewey score 1, 2, and 3 in the interim assessment as complete metabolic response. And one more important thing that they have done, they have quantified the volume of the residual lymph node, and they have defined their indication of radiotherapy depending upon the volume. So all these can be done in a trial basis. We should not generalize this result and should not just pick up from this study and apply in our setting. Similarly, the North American group also tried to identify the patient where radiotherapy can be omitted, and with the ABVPC backbone, the patient who were rapid early responder, they tried to remove radiotherapy from their protocol, and if the disease was non-bulky. And around 24% of the patient they could identify where RT could be omitted without affecting the event-free survival. So in North America and Europe, they are trying to find out certain subset of patients where RT omission is possible, but this is still evolving, and we are not sure whether we can extrapolate this to our setting. And let's see now the Indian data. And This was a study which was published by us in last month Leukemia and Lymphoma Journal, and it is the first multi-centric prospective study of Hodgkin lymphoma, where 27 centers across India took part, and total 262 patients with advanced stage Hodgkin lymphoma were treated, and 6 cycles of ABVD chemotherapy was given to them, and RT was reserved for the patient who had bulky disease diagnosis or who had suboptimal response after 2 cycles of chemotherapy. And if we look at the outcome, the event-free survival for the whole group was 81% and overall survival was 90%. But now if we look at this curve for the outcome of the patient who received RT versus who did not receive RT, and there was a significant difference. And the patient who did receive RT, the outcome was much better, 89% compared to patient who did not receive RT, and it was 74%. So we had to conclude that radiotherapy remains an integral component of advanced stage Hodgkin lymphoma with ABVD backbone, unlike with other intensive chemotherapy where omission of RT could be feasible. Now the next question is, if we switch to intensive chemotherapy, can we modify our indications? We don't know this yet. And our hypothesis is that it may not be so, because the bulk of disease in our setting sometimes in terms of overall volume may not be same as in the developed country. So with this hypothesis, actually now we are doing our next study, which is spearheaded by TMH group, which is INPOG HL03 study. And here we are using a OIPA-COPDEC backbone in which intermediate risk and high risk patients with a bulky disease are being randomized based on their response. If someone gets adequate response, they are being randomized to receive RT or to not to receive RT. So we are trying to recruit around 700 patients over a period of 5 years. And so far around 65 patients have been recruited in this study, and this is an ongoing study. This is going to be a landmark study because it is going to answer a question which is very unique to our setting. And it will, I think with OIPA and COPDEC, more and more centers are now going with this strategy, and it will redefine the indication of radiotherapy in our setting. So with that, I would like to conclude by saying that with combined modality therapy, the event-free survival of Hodgkin lymphoma has improved to 90%. Further improvement will require the incorporation of immunotherapy in our protocol. Chemotherapy and radiotherapy in Hodgkin lymphoma are not competitive modalities, but are complementary to each other. We need to maintain a delicate balance between these two modalities for optimum outcome. With more intensive protocol, the indication of radiotherapy are evolving. But in our setting with ABVD backbone, radiotherapy remains an important component of treatment plan. Thank you.
Thank you, Dr. Sandeep, for an excellent talk on advanced Hodgkin's lymphoma and for showing how one needs to delicately balance survival with late effects. Can we ask the audience if they have any questions for the chat box? Dr. Lalit has joined, I think. Dr. Lalit, he is a chairperson for our session. Welcome.
Thank you so much, ma'am. I joined in fact as panelist. They supported me in the main hall. Thank you so much, and it was very good, informative talk.
So any questions? If there are no questions, Dr. Lalit, would you like to ask any question?
No, I think he has concluded very well. Only issue was about the ABVD followed by RT versus the BCOP-like regimen in pediatric practice, because RT itself has got long-term side effects and problems.
Yes, actually, in a study in the North America, they have tried to give BCOP to advanced stage Hodgkin lymphoma, and event-free survival was again 90 to 95% in that, and that was like quite good event-free survival. But the thing is, in absence of long-term follow-up, we don't know whether these toxic chemotherapy, how much late effects they also have. So on one side, we are trying to exclude the side effect of radiotherapy, and on the other side, we are trying to intensify chemotherapy, which are also not less toxic. And increasing the dose of bleomycin and anthracycline, this will also pose toxicity. So I think, again, this delicate balance needs to be maintained, and tweaking one and intensifying other, whether this will translate into lesser side effect, this is still not clear.
Very
there
right.
is a question in the chat box. Dr. Sandeep, for Dr. Sandeep, was there any impact of the subtype of Hodgkin's lymphoma, and did that affect survival?
No, it did not actually. There was no impact of histology or subtype of Hodgkin lymphoma that was predictive of adverse outcome.
So there is another question. Can you once again please repeat indications of radiotherapy for advanced Hodgkin's lymphoma in your setting? And what late effects of radiation did you face?
So if it depends on what kind of chemotherapy backbone you are using. Again, for ABVD chemotherapy, if we are using for all bulky disease and for suboptimal response after 2 cycles of chemotherapy, these patients should be given radiation. These are like standard indications for using radiotherapy in pediatric Hodgkin lymphoma. Late effects, again, it all depends upon how good follow-up you have and how long follow-up you have. So I think Dr. Sameer from the AIMS have published their latest article on the late effect in Hodgkin lymphoma. And this is the only study which has like sizable number of one disease, patients where late effects have been reported so comprehensively. Maybe Dr. Sameer can share that in his presentation. That.
So I think if there are no more questions, we will hand over to the coordinator. And am I to introduce the coordinator, the moderator for the next session? I'm not sure. What is the plan?
No, ma'am, we'll do that. Thank you, ma'am.
Okay.
We'll be also taking questions if there are any. We still have any chance for all the attendees. If they want any questions, they can still put in the chat box. And we will be taking up those questions after the sessions. Thank you, sir, for all that inclusive talk on advanced Hodgkin's lymphoma. With the permission from the chairpersons, I will move on to the next session. And that will be a panel discussion by which will be moderated by Professor Sameer Bakshi. He is a professor in the Department of Medical Oncology, AIMS, New Delhi. So as long as you're putting up your slides, you're sharing your slides, I'll take the liberty of also inviting the panelists. And for panelists, we have Dr. Kunal Das. He's a pediatric hematologist from Himalayan Institute, Dehradun. Dr. Sushma Gurung. She's a pediatric hematologist and oncologist at Bhaktapur Cancer Hospital, Nepal. Dr. Harpreet Singh, Director, Radiation Oncology, MD, Oswal Cancer Institute at Ludhiana. Dr. Monica Malik, Professor and Head, Department of Radiation Oncology at Nizam's Institute of Medical Sciences, Hyderabad. Dr. Sunil Pasricha, he's a Senior Consultant, Department of Pathology at RGCI Delhi. Dr. Manoj Gupta, he's a Consultant in Nuclear Medicine Department at RGCI Delhi. So, Professor
Can
Sunil,
I get the permission to share the screen from my end?
Yes, you can, sir.
I can now? Okay. Share. Okay. Am I well audible and is my screen visible?
Yes, sir. Please go ahead. Yes, sir.
Okay. Thank you, chairpersons, and thank you for this meeting. And I think I'll proceed straight away to the panel discussion. And we'll go straight away to the first case. Okay. So our first case is a 12-year-old boy who presented with stage 2AX classical Hodgkin's lymphoma. The site was neck and the maximum size of the node was 8 centimeters. He was initially treated as tuberculosis based on an initial fine needle aspiration cytology and later a true cut biopsy after he was treated with TB for around 3 to 4 months. A true cut biopsy was done, which had revealed a classical Hodgkin's lymphoma. My question to our panelist, Dr. Pasricha, is how often would you find Hodgkin's being misdiagnosed as TB on biopsy and or FNAC?
Yeah, sir. Am I audible?
Yes, please.
Yeah. So good afternoon, everyone. And sir, this is not a very frequent, but yes, we do get across cases, especially when we get some, blogs and slides for review, that many patients, they get, misdiagnosed as a tuberculosis on a true cut biopsy, especially because sometimes the known pitfall is that because the Hodgkin's lymphoma can be associated with the granulomas because they incite granuloma also. So before interpreting the biopsy, the pathologist should always have a correlation with the clinical finding. Like in this case, the size of the lymph node is around 8 centimeters. So if such a massive lymphadenopathy, a chain of lymph node in a regional way, if it is involved, so a clinical index of suspicion should always be there along with interpretation of the pathology slides.
Okay, so this was the size of the node when he actually presented to us. But I'll go further and actually ask you, what is your experience? How often does TB coexist with Hodgkin's lymphoma? What's your experience? How many have you seen? Like, you have Hodgkin's in the biopsy and you also have TB in the same biopsy.
In the same biopsy concurrently. I mean,
yes.
composite.
Yes.
Yeah.
Yes.
You can say very rarely we get across, in which we prove also, like, when AFB also comes positive in the necrotic areas of the granulomatous, which is associated with Hodgkin's.
Okay.
We do get across, but it's rare. It's not very frequently. It's not frequently we are getting it.
Okay. I want to, I think, as part of the INPOX study that Dr. Sandeep was just talking about, where we had both early and advanced stage patients, I think practically 1/3 of our patients, if Dr. Amita is not here with us today, I think 1/3 of our patients actually ended up receiving anti-tubercular therapy before they came to any of us as oncologists. And I think this was the same data that we had at the time when Dr. L.S. Arya, long time back, when he published his data from All India Institute. So I still think that 1/3 of patients continue to get treated as TB before they actually present to the oncologist. Dr. Pasricha, I have one more added question for you, and I thought it was relevant because it is not relevant to this case, but I have faced it and I have discussed it with pathologists. And the question is, I have sometimes found, in fact, I have 2 or 3 cases in my practice who had an initial diagnosis of dermatopathic lymphadenitis. And they had reasonably big lymph nodes. On the first biopsy, yes, they said there is no lymphoma, but on rebiopsy, it turned out to be Hodgkin's. Is dermatopathic lymphadenitis as a pathological entity related to Hodgkin's?
So dermatopathic lymphadenitis, it occurs, when there is some skin lesion is there and there is an antigenic stimulation, that drives the paracortical expansion within the lymph node and they show the spectrum of the, lymphadenitis within the node. But as far as, the Hodgkin is concerned, we rarely find it as a differential with this entity.
Okay.
But of course, sometimes it happens that Hodgkin lymphoma, you don't have a a completely effaced architecture, and sometimes the node can be partially involved by the Hodgkin's lymphoma.
Okay, sure. So what I actually sorry, please continue. Please continue, sir.
So in that case, a true cut biopsy can miss upon the diagnosis of a Hodgkin's lymphoma if the node is partially effaced and you don't have the the full when the whole lymph node is not involved by the Hodgkin. So as far as possible, if the clinical index of suspicion is high and if a true cut biopsy is negative before subjecting the patient for an anti-tubercular treatment, if the index of suspicion for a Hodgkin is high, so I think an excision biopsy is prudent in that case.
So I think Dr. Pasricha has answered that question right on the spot, in the sense that, if you do get a dermatopathic lymphadenitis diagnosis and the lymph nodes are indeed big and there is no coexistent skin lesions, please do look at the biopsy carefully, do a rebiopsy, do a full excisional biopsy to make sure it is not Hodgkin's. Sometimes even mycosis fungoides gets associated with this, and even PTCLs have been associated or have been misdiagnosed as dermatopathic. So just keep that in mind. Going further with this case, this patient was treated with 2 cycles of ABVD, and following this, he underwent a CCT scan. The CCT scan showed a partial response with the lymph node size now being 2 centimeters. My question is to Dr. Manoj. Would you have preferred PET-CT, or are you okay with CT?
Sir, I think like in this particular case, 12-year boy with a cervical lymph node, I think for the staging, definitely we need to have a PET scan. And not only it will tell us whether the lymph node, which most of the time the Hodgkin lymph nodes are avid, it will make sure that the disease is avid, and we will also know whether the disease is anywhere else in the body or not.
No, sorry,
Okay,
sir,
so
I'll just interrupt here. I'm talking about the interim scan here. The patient had initial stage 2AX disease. The site was in the neck. Now, after 2 cycles of ABVD, the patient underwent a CCT, and the CT scan report by the radiologist based on the criteria was a partial response. The size of the node was 2 centimeters now from 8 centimeters. So my question is, would PET be better according to you, or would CT be okay? And in the same go, I'll ask another question, but that will be to somebody else. So that's my question. Do you think PET would be...
Okay. So I understand your question. So you're asking at this point of time whether in the interim scan, in the interim evaluation, whether PET scan would have been giving a better information or CECT would be sufficient. I think this is your question.
Yes, that's my question.
I think, sir, in this particular situation, because 2 centimeter size is a sizable, node, we need to know whether it is actually harboring a disease or not. So if we do a PET scan here, and if the PET scan is negative, then we are at least sure, because we know, as a history of Hodgkin lymphoma, most of the Hodgkin lymphoma are avid. So we can think in that corollary, and then if the PET scan is negative, then we can think that the patient is likely to have a complete response. Otherwise, with this much size, we will left with the complete response unknown, or because there's almost 75% of decrease in this size. So we will in the category of like borderline, whether the patient actually has a partial response or a complete response unknown. So I think the PET scan would definitely help.
So you are saying you will be, so according to you, you will get a better definition whether it is a CR or a PR. So I agree with that. You will get a better definition if it's a CR or a PR. But I would just share one of my own studies on CT versus PET-CT. It was what we found was that in terms of actually long-term outcome, provided you are not changing treatment, it was the end-stage PET which really made an impact. But nevertheless, I buy your point that it would still tell us if it's a CR or a PR. But then my question comes to our colleagues from medical oncology. I'll open this question to Dr. Kundan. Dr. Kundan, let's agree with Dr. Manoj that yes, we should have got a PET scan. Would now your treatment change? This was a stage 2AX bulky disease. Had this been CR or PR? Of course, it has better characterized it. There is no question about it. If you say it's a CR, it's a better characterization of your outcome. How does it change your treatment, if at all? Or it doesn't. It could be that it doesn't change your treatment. So my question is to Dr. Kundan. Is Dr. Kundan there?
I don't think so, sir. I think we'll have to switch the question to another panelist.
Okay. Dr. Sushma, are you around? Dr. Sushma?
Yes, sir, I'm here, sir.
Yes, Dr. Sushma, may I know your thoughts on this? How would you respond? I mean, would you think that knowing a CR or a PR in a bulky disease, besides knowing it as a better characterization, will it alter your treatment response or your treatment intervention?
So if there is complete.
Sorry, somebody is saying something.
Yeah, Dr. Sameer, Dr. Kunal is on the panel, not Dr. Kundan.
Oh, sorry. I'm sorry, Dr. Kundan. Sorry for Dr. Kunal. I'm so sorry for not telling your name correctly. Sorry. Dr. Sushma, anything from yours?
If there is a complete response, but considering the bulky disease time of in of radiation therapy treatment in this case.
Okay. Okay. I'll also take the response from Dr. Kunal. Dr. Kunal, sorry for not correct telling your name correctly. Please, Dr. Kunal, may I know your thoughts on this as well?
Yes,
besides
sir.
Dr. Sushma?
Yeah, sir. Actually, in the case like after in a bulky disease stage 2, after 2 cycle, you said correctly, doing a CT or PET-CT doesn't make much difference in pediatric because we are going to proceed with ABVD. But yes, adult side, there were studies which were omitting bleomycin and or escalating to BA COP earlier. But for pediatric, we are going to follow ABVD at least 4 cycles for stage 2 bulky disease. Then doing the assessment to de-escalate or escalate or plan for radiation. Now we are not omitting radiation in bulky as of now. So interim PET is actually for our more of like with direction we are going, but actually it doesn't guide the treatment plan.
Okay. So this patient, the treating
can I
team,
have a small query?
Sure, please.
Yeah, I think right now the discussion is whether the interim PET scan at 2 cycles, we do a CT or PET scan, it will not going to change the treatment management. So my question is just if we are going to continue with the 2 more cycles of AVD with the stage 2 and bulky disease, then what is the point of doing an interim PET scan here or a CT scan?
So I think, Dr. Manoj, the answer to that is there are 3 responses one could get on a imaging. One is, in fact, my questions will get answered. The question that you are answering will get answered in my subsequent questions that are coming up. So I think I'll wait. I'll answer your questions as we proceed. Okay. I'll answer this. Okay. So now my question comes to our radiotherapist, Dr. Harpreet. Is Dr. Harpreet there? Is Dr. Harpreet there? Dr. Harpreet and Dr. Monica?
Dr. Monica, yes, I'm here.
Dr. Monica, my question is a yes or a no. In this patient, after 2 more cycles, that means after 4 cycles, the patient achieved the CR. Question is, you will give radiotherapy, yes, no?
Yes, we will give radiotherapy for this patient in view of the bulk.
I agree with you. I, as the moderator, I'm in agreement with you as well. We'll proceed. If yes, what type of radiotherapy would be in terms of the field and the dose?
So in terms of the field, this would be an involved site radiotherapy where the initial involved site would be treated. And since it's a CR, the dose would be around 21 gray.
Okay. So may I ask you one more thing? If this was a CR in the interim, would your dose be any different than having the CR at the time of 4 cycles, or it will be same?
The dose following a CR is 21 gray. If it was a PR, we would have gone up to 30 gray.
Okay. So let me ask you one thing. If a CT scan was done and the CT scan at the end of 4 cycles had shown a 2 centimeter lymph node, which by the CT scan criteria, the cutoff is 1.5 centimeter, it would be a PR. And in that case, your radiotherapy dose would have actually been higher. So can we conclude that doing a PET scan in a disease like this has aided you to reduce the dose of radiotherapy? Are we in agreement with this?
Yes, sir.
Okay, perfect. Now I'll go to what Dr. Sandeep was talking about in his previous talk, and somebody had raised a question about the late effects. We had a recent publication in Pediatric Blood and Cancer, and this was a follow-up of more than 150 patients of Hodgkin's lymphoma treated uniformly with ABVD, and majority of them had received radiotherapy as well. And if you would have asked me 20 years back, I would just say that I will first like the patient to survive and not talk about late effects. But having been in the field now for 2 decades and having seen some of those patients, I start thinking that yes, late effects matter. At the time of my beginning of my career, I didn't think 2 decades ahead of time, but now I do. So in terms of radiotherapy, this patient needs radiotherapy. How would you decrease the morbidity? Virtually every single case or 80% of cases who got neck radiotherapy ended up having subclinical or overt hypothyroidism. And personally, I would not like a patient with a more than 95% survival rate to also get hypothyroidism. So I would ask you, either Dr. Harpreet or Dr. Monica, what are the added measures, newer modalities, newer techniques of radiotherapy that you would use so that these side effects are cut down?
So,
yeah. Dr. Monica, you continue.
Yeah. So, intensity modulated radiation therapy is one of the techniques where we can significantly reduce dose to the organs at risk, including the thyroid gland, especially when we are treating the unilateral neck. And then we also have the concept of involved node radiotherapy, where the baseline PET is done in the treatment position on a flat couch, which can be fused with the scans done subsequent to the chemotherapy, and we can use this information to even decrease the radiation fields further.
Okay.
And of course, the interim PET is also helping us to plan our dose. So the lower the dose, the lower will be the late effects. So all these measures can be done to reduce the incidence of late effects in these patients.
So I'm not a radiotherapist, so I want to know, is involved node radiotherapy as you described, is it routinely being done?
It is not routinely being done. Actually, the prerequisite for that is the baseline PET-CT for the patient should be done in the position in which they will be placed for radiotherapy. So with the immobilization cast, and it should be done on a flat couch.
So it has to be pre-planned.
That is not practiced widely as of now. We are not able to do that. So there has to be greater awareness about this modality, and I think it should become a routine practice for lymphoma patients to be to undergo their baseline PET in such a way.
So can we pass a message to our audience here that in bulky disease, where we all agree practically, and it's not a controversial topic, that radiotherapy still forms an important and equally important part of the treatment of Hodgkin's lymphoma, can we say that in bulky disease of Hodgkin's lymphoma, we involve the radiotherapist right from the beginning and do the planning, if at all possible, for the involved nodal radiotherapy, as Dr. Monica has said? I think that could be one message for all of us.
Sir, in addition, I would like to add,
yes,
that what we do is now we more frequently add our organs at risk, like the heart, the other coronary arteries, in our contouring, so that we can reduce the dose to them as far as possible without compromising on the dose to the residual tumor or the bulky disease, whatever way it is. That is an additional way. And secondly, what we do is when we plan, we try to omit the normal organs. Let's say we are treating the mediastinum, the lungs and the heart will not be in our tumor volume markings.
Okay.
So that is an additional way which we can do to prevent the side effects or reduce the side effects.
Okay. So may I just ask the organizers how much more time is there for me? I will proceed according to that. How much more time is there?
We have 5 minutes.
Okay, we have 5 minutes more. Okay. So if the same case was stage 2A Hodgkin's, non-bulky, and this patient achieved a CR post 2 cycles. And this question is now open. I will put this question first to Dr. Harpreet. What would be your choice here? 2 more cycles of ABVD, 2 more cycles of ABVD plus RT, RT only, or no further treatment? And then I'll put this question to one medical person.
It should be, I think, 2 cycles of ABVD plus RT.
Okay, so that's your choice. Okay, yeah. I'll put this question now to our medical colleague, and Dr. Sushma.
I think so. 2 more cycles of ABVD.
Okay, so I'll tell you, Dr. Harpreet, when I started 2 decades ago, I would have done exactly what you are doing. I would have used 2 more cycles of ABVD and RT. And in fact, till very recently, I practiced with 4 cycles of ABVD and radiotherapy for all early stage Hodgkin's. But having seen today, my practice is what Dr. Sushma said. If it's a CR, I would probably end with 4 cycles of ABVD and not give radiotherapy in a non-bulky disease in a child. I am not sure what others would say, but we will probably not have a controversy here because that is, at least in the fraternity from the medical side, a lot of them, and I was one of those people, I was criticized that I used a lot of RT, but for a non-bulky disease in CR, dose of use of radiotherapy would probably be avoided.
Okay, yeah, taken,
okay.
Well taken.
Okay, I will go to now, since time is short, I'll go to my last case. It's a 15-year-old boy with stage 2B Hodgkin's lymphoma, a primary site being mediastinum, treated with 6 cycles of ABVD. He achieved a CR post 2 cycles, and a CCT done at the end of treatment was also CR. 6 months later, he came on follow-up, but his scan showed a 5 centimeter new mass. He had not received radiotherapy. He came with a 5 centimeter mass. This is how the scan looked. I have just one picture that I could get. I could not get more pictures since I've been off work for the last 4 or 5 days. So this is the CT scan showing the thorax. My question is now to Dr. Monica. What's your next line of treatment? You have 6 choices here. Normally you get 4 choices. Here you have 6 choices and you may choose anyone. And I'm going to put this question to 2-3 more people. Yes, you will have to be quick, Dr. Monica. Read the choices quickly, and because then I'll pass it.
Yeah, I would prefer to go for an additional biopsy in this patient.
Okay, so you would like to do biopsy, and biopsy if positive, then?
From the scan, at least the disease looks a little bulky, so probably go for chemotherapy and then radiation.
Chemotherapy and radiation. My question now to Dr. Kunal. Dr. Kunal, you also have to answer. Please, all my panelists, please be prepared with your answers. I need the answers right away. We can't have so much waiting time.
Yes, sir. Can you
What's
listen?
your answer here? Dr. Monica has given the answer.
Sir, to do the biopsy and followed by, if it is positive, do the salvage chemotherapy.
Salvage chemotherapy followed by transplant. Okay.
Transplant is a plus minus, because if it is limited to that, so after biopsy, if it is disease, I will go for PET-CT.
It's an early relapse. If at all, it is relapse.
Yeah, if it is a relapse and localized to that area only, then we have not used the transplant radiation modality.
So I'm sorry to disappoint all of you. It is something that I wanted to put it before all of you, that the answer in this case is going to be something else. May I have the anybody else who wants to give in a viewpoint here? Nobody else wants to. Okay.
So may I add something? Yeah.
Yes, please. This is the last question and last case.
Yeah, I think this is a common side of thymus as well. So we need to remember that there is a thymus rebound is an entity which is existing. Okay?
I'm so glad, Dr. Manoj, you answered it.
Yeah. So I think we need to make sure that.
Absolutely. So I wanted to put this case only for this reason, that the right choice in this answer is that I do not agree with either of these approaches. And Dr. Manoj hit it right away. And let me tell you, this patient actually had a CT scan done at a place and was reported as progressive disease. And actually he was planned for a PET scan and a biopsy. And we said, wait it out. Review the scans, and it was just enlarged thymus, as Dr. Manoj rightly said. Please remember, few months later, a lot of these patients come with an enlarged thymus, and my message is don't miss that, don't treat it. It's not the first case that I've seen like this. There have been 3 or 4 such cases in my practice where people have planned a biopsy or a PET scan thinking it's a relapse. I will end the panel discussion here from my end, and it's open to questions now. Thank you very much.
Yeah. Thank you, sir.
Thank you, Dr. Samir, for an excellent session. Very interactive and very, very practical questions. I want to ask one question. What is the difference between INRT and ISRT? Now that we have a lot of radiation experts here, can we get this question answered? What is the difference between INRT versus ISRT?
Yes, let's have either Dr. Monica or Dr. Harpreet.
So basically, ISRTs involve site radiation, which is treatment of the initial site of disease. Involved node radiation, or INRT, is basically defined as treatment of the initial node or nodes which were involved. So the difference basically is in how the initial CT or the PET CT was done. If it was done in the position that is going to be used for the treatment on a flat CT couch, and the involved initial nodal or site is contoured on that and then fused with the post chemo images, that is technically called as involved node irradiation. So it is basically a difference in the technique or the way in which the initial scan was done. Practically, and I think Dr. Siddharth has put this point in the chat box also, that practically there is probably very little difference in terms of the treatment volumes in the 2 modalities, although theoretically and by definition, the volumes might be slightly lower when we are treating with INRT. But whether this really makes a big difference to the practical treatment is debatable, and it usually does not. And with the modalities that we have now for fusing the scans and deformable registrations, where you can easily fuse the pre and post chemo scans and define volumes, it does not make much of a difference in terms of practical implications for that patient's treatment. So both these are actually modalities where only the initial involved nodal region or site is treated against IFRT, which was involved field radiation, where the entire nodal region was treated. So this significantly definitely reduces the volumes as compared to involved field radiation, where the entire, if cervical node is involved, the entire region or all the cervical nodes will be treated in that modality. So nowadays, because we have PET, we don't usually practice IFRT anymore. So it is usually an ISRT or an INRT which is practiced.
Thank you for that clarification. I think most of us, it would be a good information, learning information for us. So with that, I think as the time is running out, we will hand over to the coordinator for the next session for rhabdomyosarcoma. Okay. And thank all the speakers, moderator, and panelists for an excellent session. Thank you very much.
Thank you. Thank you, panelists. Thank you.
Thank you, Dr. Samir, and thank you all the panelists and Dr. Sandeep Jain for a wonderful session. And now let's move on to the second session. And I will hand over the proceedings to Dr. Nishtha to conduct the session.
Now we will begin with our second session, which is on rhabdomyosarcoma. For the session, I would like to invite chairpersons, Dr. Madhu Prastogi, head of Department of Radiation Oncology, RML Lucknow, and Dr. Sajid Qureshi, Professor Pediatric Surgical Oncology, TMH Mumbai. Hello.
Hi, good afternoon, everyone.
Hello,
yes,
sir.
Yes.
Dr. Madhu.
Dr. Sarjan, please continue.
Okay, sir. Good afternoon, sir.
Good afternoon.
For the talk on rhabdomyosarcoma, I would like to invite Dr. Jaskaran Sethi, Senior Consultant and Unit Head Pediatric Radiation Oncology, RGCIRC, New Delhi. Sir will be delivering a talk on radiation in young children with rhabdomyosarcoma, RGCIRC experience. With this, I would like to hand over the proceedings to Jaskaran, sir.
Yeah, thanks for the introduction, Nishtha, and good afternoon, everyone. I hope I am audible and you can see my screen also. So in the next 15 minutes or so, I would like to take you through how we treat rhabdomyosarcoma in young children at our hospital. We all know that rhabdomyosarcoma is a disease of the young children. Usually it peaks at in children under 4 years of age. It can arise from any part of the body, and it is the most common pediatric and adolescent group soft tissue sarcoma. The most commonly seen histology is embryonal. The most common age group we see it is in 1 to 4 years. And the most common majority of our patients actually are in group 3 IRS grouping. So the multimodality treatment of rhabdomyosarcoma includes chemotherapy, local treatments with surgery and radiation, and recently the biological agents. However, it is important to optimize the treatment based on the histology, age, burden of the disease, and this has helped us evolve risk categories which define the treatment and do not lead to under or over treatment in these patients. The goal of management of treatment in rhabdomyosarcoma includes a long-term cure, improvement in the quality of life of these young patients. The endeavor is to have maximum functional preservation and a good cosmesis. Whether it is a limited stage disease or a metastatic disease, we all know that the prognosis of RMS is strongly determined by the ability to achieve a local control. And this is where the role of radiation is very, very important. So the guidelines from the COG, from the soft tissue sarcoma committee, have defined the doses for radiation in these patients. For group 1 alveolar patients, the dose is 36 gray. For group 2, according to the nodal involvements, it can vary between 36 to 41.4 gray. For group 3, it is 50.4 gray. For orbital patients, it is fixed at 45 gray. And group 4 patients should be treated as in other groups, and wherever possible, we should try to include the metastatic sites also. The target volumes are also pretty well defined in the literature. The target volumes are contoured as pre-chemotherapy volume and post-chemotherapy volume. Fusion of the pre-chemotherapy and the post-chemotherapy MRI is done with the radiotherapy planning scan. And it is important that we note that only clinically and pathologically involved nodes are contoured. There is no prophylactic irradiation of the entire nodal chain in the CTVs. the margins usually between 5 to 10 mm, and the PTVs are also generated having a margin of 3 to 5 mm depending upon what site we are treating and the institutional protocol. Now, there are certain situations that we encounter when we treat these patients who have had induction chemotherapy. Sometimes the induction chemotherapy does not lead to a great volume change in the disease. We have a kind of stable disease. It is in these patients that the GTV2 is contoured just like GTV1. Whereas on the other end of the spectrum, we have patients who have a huge response and go into a complete response by the time they are referred for radiation therapy. Here, there is no need to contour a GTV2. The CTV in such cases would be the margin given on GTV1 alone. So it is very important that we take these into consideration, and we do have a good quality MRI, pre-chemotherapy and post-chemotherapy. This is especially I'm saying because many a times these patients do not have a pre-chemotherapy MRI when they are referred to us. So apart from delineating the tumor target volumes, it is very important to very meticulously contour the uninvolved structures in the vicinity of the target volumes. Especially so because these structures can have long-term radiation toxicities. For the residents who are attending the CME, it's very important to remember that children are not to be considered as just young adults. Determining the relationship between the spatiotemporal distribution of the dose and the toxicity profiles is complicated for children because they have a mosaic of tissue which is developing at different rates and temporal sequences. So it is very important that apart from contouring the normal OARs like the rectum, bladder for pelvic cases, we also do contour the triradiate cartilage in the pelvis for these children. And when we are doing cases, let's say parameningeal cases, apart from contouring the parotids and the spinal cords, we should also contour the spinal ossification centers, which can have, if we are not contouring them properly or not caring about the dose to these structures, can lead to developmental difficulties, deformities in these children. So recently, Pentec has come out with the OAR constraints, and we use those in our hospital. So this slide I just brought in to show you the vertebral radiotherapy dose distribution, which should be our goal when we are treating the pediatric age group. As per the recommendations of PSYOP radiotherapy working group, we should aim for having a homogeneous dose distribution from left to right and anterior to posterior. This is very important in the pre-pubertal acceleration phase, and we should try to have the gradient up to 2 gray for children under 2 years. And for children above 2 years, up to the pubertal acceleration phase, we should limit this gradient to about 5 grays. Once the pubertal acceleration phase is achieved, the gradients, all the gradients are acceptable, and we should not be very bothered about this. So here you see a 2-year-old child with ossified triradiate cartilage, and these should be contoured very, very meticulously so that we can limit the dose to these structures. We are all aware of the detrimental effects that radiation can have on the growth of the growing skeleton in the children. And with the meticulous contouring of these structures, knowledge of skeletal anatomy and maturation, and a meticulous planning, we should try to keep the dose to minimum so that the side effects are minimized. So we recently started analyzing our data for RMS at Rajiv Gandhi. In the last 12 years, we have got 131 patients of biopsy-proven rhabdomyosarcoma, out of which 18 patients are in the pediatric age group. 81 patients, sorry, are in the pediatric age group. Out of these patients, about 34 patients did not either take the treatment at our hospital or had just come for a second opinion. So our analysis limited to 47 patients. The majority of our cases are males, and the most commonly seen age group is 1 to 4 years. We have also treated around 9 infants, and the youngest one at the time of starting the treatment with chemotherapy was just 3 months old, and at the time of delivery of radiotherapy was 6 months old. And this youngest lot poses the maximum challenge for us as radiation oncologists in terms of requirements for their treatment delivery, which include daily anesthesia, the setup uncertainties which come up in delivering these radiation to these cases, and also the ability to have a reproducible setup, especially when we are treating the pelvic cases, to have a reproducible bladder protocol in these patients. Disease characteristics, if we look into our patients, the most of our patients were at the unfavorable sites, with parameningeal being the most common site. Histologically, as in the world literature, most of our cases were the classical, embryonal, and botryoid, and most of our patients are in the intermediate risk group categorization. Treatment-wise, almost 83% of our patients got induction chemotherapy, and 1/3 of our patients, almost 32%, had surgery as the local therapy. 4 of these patients who underwent surgery, radical surgery, had positive margins for which adjuvant radiotherapy was given. Coming to the radiation side, we had about, most of our patients received radical radiotherapy with salvage radiotherapy in few patients, in very less patients, and adjuvant radiotherapy for 7 of our patients. In our institute, we are going away from, we're actually not planning our patients on 2D radiotherapy anymore. And we do at times use the our simulator, X-ray based simulator, to plan these patients. But most of our patients are having CT simulation and conformal radiotherapy being delivered to minimize the side effect of radiation. In 2 of our patients who had vaginal RMS, we have utilized sorbo applicators. So coming to the local control in the KM graph, we see that 6 patients out of our 46 patients which are analyzed had a local relapse, and out of these 4 patients never had got radiation, had radiation, and 2 never had radiation. So if we look at this graph on the right side, we see that they are going apart, but we have not reached any statistical significance because our patients in the non-RT group are very, very less. Most of our patients are head and neck primaries. And in the head and neck, parameningeal is what is our bulk, with orbit and non-orbit and non-parameningeal as the other subsites. So if we go to the world literature also, the most common sites is the head and neck, and 40% of the cases are in head and neck area. The parameningeal site here is the predominant site in most of the literature, and it is one of the very difficult sites to treat. It is a site which includes the middle ear, mastoid, nasopharynx, nasal cavity, the paranasal sinuses, parapharyngeal region, and the ITF. It has a complicated anatomy and a difficult site to treat because radical surgery causes a lot of functional and cosmetic dysfunction in these patients. So most of these patients would have a gross residual, or only a biopsy is done in these cases, and they are the candidates for receiving radiotherapy. So I'll just show you one case of RMS, who was a 2-year-old child having disease of the external auditory canal, which was extending into the Eustachian canal, involving the structures of the middle and the inner ear, and a little bit of intracranial extension was also there. This patient was planned in supine position using a three-clip Orifit cast on a pediatric neck rest with hands on his side. And the CT scan was taken from the vertex to the root of the neck. Then the registration was done. The planning scans registration was done with the pre and the post chemo MRI. And the pre-chemotherapy volume, you can see the GTV being generated in the blue and the CTV in the green one. The dose prescription was 41.4 Gray to the PTV. The post-chemotherapy contouring was done with the registration of the post-chemotherapy MRI, and you can see the volume of boost as 50.4 Gray in yellow here. This patient was then planned, and we could get a very good dose distribution, which covered the whole tumor in entirety, and it gave us good sparing of the normal organ structure, normal structures at risk. Only the problem came in the right parotid and the TM joint because they were too close to the target volume. So now coming to the bladder and prostate RMS cases, it is very important that when we are planning these patients for radiation, we have to position them very accurately, because this helps us reducing the acute toxicity. It helps us deliver the treatment accurately. It gives a better compliance for the patient for the treatment and makes the delivery of anesthesia also comfortable. So this child had a periurethral mass, and we planned this child in a frog-leg position, and we took the penile shaft away from the target area by placing it next to the abdominal wall within the Orifit cast, so that we minimize the volume of penile urethra in the high dose volume, which you can see from here that the shaft is against the abdominal wall, and we've taken the penile urethra away from the high dose region. So in this slide, we have a 6-month-old patient with prostatic RMS, and who was taken up for definitive radiotherapy to a dose of 50.4 Gray. And this child was just 6 months old, so we utilized daily anesthesia here. And we wanted to have a full bladder protocol so during the planning, but it was very difficult in a child who was 6 months of age to have that. So we put a Foley's catheter and instilled a definite volume of water fluid to keep a reproducible bladder during the subsequent during the planning and subsequent treatment delivery. So in this patient, the other issue that was there was that the pre-chemotherapy GTV and the post-chemotherapy GTV were not, there was not much shrinkage of the actually tumor with the induction chemotherapy. So we wanted that we take away as much bladder bowel away from the high dose region, and also placement of the Foley's possibly helps prevent the formation of urethral strictures, which is very common in these patients with the prostate RMS. So we treat our patients usually using VMAT, especially those who are having anesthesia support, because it shortens the treatment time. And we don't have to stop the treatment for repeat doses of anesthesia during the treatment. In the end, I would like to say that patients once treated with radiotherapy need to have a long-term follow-up, both for the disease and for the sequelae of radiation. We need to do appropriate imaging and conduct tests and do a thorough clinical examination on a regular follow-up so that we catch facial hypoplasias, we catch long-term long bone fractures, are able to document our spinal growth anomalies and any derangements in the thyroid function or the endocrinal profile of these patients. With this, I would like to end my talk. Thank you very much. And I would like to hand it over to the coordinator.
Thank you, sir. Thank you for such a great talk. I would like all of you to kindly post your questions in the Q&A box. And in the meanwhile, we will start with the next session, which is the panel. For the panel, I would like to invite the moderator, Dr. Anjali Pahuja, Consultant, Department of Radiation Oncology, RCIRC. The topic for panel discussion is head and neck rhabdomyosarcoma, challenges in local control. The panelists, for the panelists, I would like to invite Dr. Shalini Mishra, Consultant, Pediatric Surgical Oncology, RGCIRC. Dr. Manas Kalra, Senior Consultant, Pediatric Hemato-Oncology, Sir Gangaram Hospital, New Delhi. Dr. Vineet Anand, Consultant, Pediatric Hemato-Oncology, Rotary Ambala Cancer and General Hospital, Ambala. Dr. Punita Lal, Professor, Department of Radiation Oncology, SGPGI, Lucknow. Dr. Nehal Khanna, Professor and Consultant, Radiation Oncology, Tata Memorial Hospital, Mumbai. And Dr. Maushmi Suryavanshi, Senior Consultant, Molecular Diagnostic, RGCIRC, New Delhi. With this, I would like to hand over the proceedings to Anjali ma'am. Good afternoon. I'm audible. And the screen is clearly visible.
No, you need to share your screen, ma'am.
So minimize. Minimize. आपने ओपन किया?
Is it visible now?
Yes, we can, ma'am. Make it full screen.
Full screen कर दो.
Okay. So.
No, ma'am. आपको slide share करना पड़ेगा, ma'am, please.
Can you see the screen now?
Yes, we
is
can.
the presentation on the screen?
Yeah, we can see the presentation, but you need to be a full screen.
Just put it slideshow. You have not put
Yes.
slideshow.
This is the slideshow.
Okay. We are seeing it. We can see all your slides on the side also, and this is not showing slideshow.
Okay, just a second.
नीचे है ये इधर इसके नीचे रखना. Right, go right. This one.
Is it okay now?
No, we can't see.
We don't have your screen at all. So get out of screen, share screen, and go back into share screen. Exit share screen and then go back again. Slideshow.
Yes, ma'am.
Okay, I think it's okay now.
Not yet.
No, slideshow should be there.
IT, please, career.
IT is here. They are doing it. I think.
Meanwhile, you can ask some questions from our experts.
Otherwise, should I load your slide, ma'am? Yeah, now it is
Yes,
coming perfect. Yes.
we are good. We are good.
Okay, right. So this is about a 1-year-old male baby who was brought to an ENT specialist with complaints of noisy breathing since birth. The child never had any difficulty in feeding or any increased irritability, no episodes of cyanosis or any stridor. So at this hospital, contrast enhanced CT net was done, which showed a heterogeneous lobulated mass about 2.6 centimeters in maximum dimension, but impinging over the oropharyngeal airway. And it was extending inferiorly into the piriform sinus. So a lateral pharyngotomy the first question will be to the surgical oncologist, Dr. Shalini. Ma'am, suppose this child was brought to you by the parents.
Dr. Anjali, can you just repeat the last part of your slides? We couldn't hear you well.
Okay. This child was taken to the ENT specialist who did a lateral pharyngotomy and total excision of the mass, not suspecting it to be a malignancy. However, the final histopathology came out to be alveolar rhabdomyosarcoma. So my first question is to Dr. Shalini, our pediatric surgical oncologist, that if this child had been brought to you in the first place, then what would have been your approach?
So there is some echo. Yes, now it's better. So thank you, Dr. Anjali and Dr. Jaskaran, for this very nice meeting. Obviously, this is a difficult case, a small child with a head and neck tumor, and definitely there is some kind of airway compromise, although it's just a noisy breathing. So if on the radiological imaging, we think it's a solid tumor enhancing with contrast, and there's a suspicion, should ideally, if the child is stable and not in airway obstruction, we should do a CT guided biopsy if that's possible. It's probably possible looking at the images. Of course, with the help of anesthetist and our intervention radiologist. And so this is a difficult area. It's a parapharyngeal mass, and so it'll come in the parameningeal group. So rhabdomyosarcoma is a little, we can say it's a different kind of tumor, because not only does the size of tumor, lymph nodes and metastasis determine the staging, the site of the tumor is also very important. So whether it's a favorable or non-favorable site. And coming to head and neck rhabdomyosarcomas, we have 3 different categories, and one is the orbit, which is an excellent outcome. Then we have the non-orbit, non-parameningeal, which are better. And of course, we have the non-orbit and parameningeal. So this child would probably fall into that category.
Right. So, ma'am, this is if the child was stable. However, if the child was brought in respiratory distress, any change in your approach?
Definitely, if the child was having an airway compromise, we would need some urgent intervention, either debulking, if that seemed to be feasible because the tumor is small, or of course we don't use debulking for rhabdomyosarcoma. We aim for an excision, but here I don't know how much margin we can get with reconstruction. The location is such, and it's a small child. And the second thing is probably we might have to keep in mind that this child will need a tracheostomy if we are going into if there's an airway compromise, and just to tide over that time, we can probably do a temporary tracheostomy also. Even managing a tracheostomy in a small child can be difficult, but that should be one option.
Right. So one thing is that if we have malignancy in mind, we do not start steroids before obtaining a biopsy. Our first attempt is to obtain a biopsy and manage the respiratory distress with the tracheostomy, as you said, and if required, a debulking surgery. Am I right?
Yes, yeah.
And you've already answered this question that this being a parameningeal site with very less chances of getting clear margins, you would rather prefer a non-surgical approach as of now. So
once we get a biopsy proven as rhabdomyosarcoma, we'll probably first give neoadjuvant chemotherapy, and then because doing upfront surgery in rhabdomyosarcoma, I think the most important things are, one is that the surgeon should be sure that we'll be able to get at least, if not negative margin, at least a gross total excision. We'll be able to remove, because this particular surgeon, I think they didn't suspect and they've removed the tumor piecemeal. So which is something which is not acceptable for oncological setup. Anyways, at least they saved the child's life, so I'm grateful for that. And the child did not go into any airway compromise. The second thing is that there should not be any functional or cosmetic disability. So these are the things that we really look into, a lot of organ preservation. And we do have other options like radiation, of course. We know these tumors are very chemosensitive. They are very radio sensitive. So we do not like to do any morbid surgery, especially upfront.
Right. Okay. So in this child, now this child was brought to our institute with the diagnosis of alveolar rhabdomyosarcoma of a parapharyngeal site, and further metastatic workup was carried out. The case was discussed with the operating specialist, the ENT specialist, and he confirmed that it was a piecemeal resection with possibility of tumor spill in the operated site, at the operated site. So, Dr. Manas, this question is for you. Is there any pertinent information that you would like to have from the pathologist besides the diagnosis of a rhabdomyosarcoma?
Thank you, Dr. Jaskaran, Dr. Anjali, and the Pediatric Medical Oncology team of Rajiv Gandhi for having me here. So on the first question, I would also like to say that, where debulking was being, thought of as one of the possible treatment modalities, these are exquisitely chemotherapy sensitive tumors, most of the pediatric small round cell tumors. And sometimes we have administered chemotherapy just immediately after the biopsy has been taken, even before we have the full histopathological and immunohistochemistry based diagnosis. Just on the frozen, when we come to know that it is a small round cell tumor, we have administered chemotherapy as a life-saving measure, because these tumors just respond and melt away immediately, and we do not have to do very moribund surgeries for these patients. And once the tumor is smaller, we can have a definitive plan once the IHC and everything is back. So in this particular case, I would say that the child is lucky. He's had a surgery. The child has done well. Often a surgery done at such a point of time, in fact, delays the administration of chemotherapy, making things even more difficult. So, that decision is very, very crucial, and it has to be a completely multidisciplinary decision when we are talking about such a sick child. As far as this particular patient is concerned, where, we have been told that this is an alveolar rhabdomyosarcoma, staging workup is very, very important. And that has to be done at the very outset to know whether the disease is metastatic or not. And when we look at the histology, we need to differentiate between alveolar and embryonal, which are the two common histologies. The other ones being spindle cell and the pleomorphic, which are kind of rare, relatively rare in the pediatric age group. The other important aspect would be to look at the fusion of the FOXO gene mutations that are seen in cases of rhabdomyosarcoma. And if you have a PAX3 or a PAX7 fusion positivity, which I think in this day and age is absolutely essential for every pediatric rhabdomyosarcoma, I would say I think that is a very, very important investigation modality to be done for every such patient. More and more the classification from the conventional histology is actually moving towards a fusion positive or a fusion negative rhabdomyosarcoma, which clearly have very different outcomes.
Right. So, Dr. Manas, we'll come back to you in a moment. We'll just move to Dr. Moshmi for a while. Dr. Moshmi, is the pathological diagnosis of rhabdomyosarcoma and its subtype largely a morphological diagnosis, or is it purely immunohistochemistry based?
Yeah, first of all, Dr. Anjali, I would like to thank the pediatric oncology and the radiation oncology team for giving me this opportunity. And coming to the question, rhabdomyosarcoma in children is mainly of three types. So one is the embryonal, the other is alveolar, and the third, which is the newer one, is the sclerosing or spindle cell rhabdomyosarcoma. Okay, if it is a classical histology, probably like an embryonal at times has a classical histology, then yes. But alveolar, especially if the histology is, again, there are classical patterns, but the tumors don't read books and there are mixed histologies also. Then you need certain markers which has to be done. There are certain IHC markers like your myogenin, your desmin and MyoD1, which have to be done on IHC. And then there are certain molecular investigations which should be done. There are some which are right now in the guidelines, and there are some for which we have a huge data, robust data coming up, which will be subsequently added in the coming classifications also.
Right. So, what are the you I think already answered this question. What are the mandatory markers? You said myogenin, MyoD, and desmin.
Yes, but look, there are three main groups which are defining these pediatric tumors. One is the COG, CWS, and the European soft tissue sarcoma group. So these are essential, but besides these, there are other markers also, which some of them recommend, like your EGFR or HMGA2, etc. But these three are essential found in all the three main groups we were classifying. And this is beyond like the molecular markers. This is not molecular, is besides this. Okay.
So, any role of NGS in non-metastatic RMS?
Yes. Actually, look, from a diagnostic point of view, embryonal usually has a very good prognosis. Alveolar has a bad prognosis, and alveolars with a FOXO fusion present, which can be either with the PAX3 or PAX7, usually have a bad prognosis. And then there is the third, that is the sclerosing group, which is further divided into three subtypes. One is the infantile, which have your VGLL2 fusions or NCOA2 fusions. So these patients do very well. So these are usually congenital rhabdomyosarcomas, and these patients do very well. Then there are some mutations in MyoD1, and these patients do very badly, and they have to be identified, and especially if they are in the head and neck tumor region. And then even TP53 mutation, if they are found, these patients also do very badly. And of course, you have to keep in mind that you might find a Li-Fermani syndrome. A patient who is having a germline TP53 mutation can also present as a rhabdomyosarcoma, especially your embryonal rhabdomyosarcoma. So those things have to be kept in mind, at least for the workup. And they're essential, I feel, especially if you feel it is a alveolar rhabdomyosarcoma, is a FOXO fusion, which is bare essential, which should be done, at least for now.
Okay. So, rightly said, there is a plethora of phase 1 and phase 2 trials which are going on to, they're targeting the different developmental pathways. And this is a big list of drugs that is coming up. And as you said, that PAX fusion positive or negative distinction is the key finding in classification of rhabdomyosarcoma. It is said that PAX3 FOXO1 fusion do worst. PAX7 fusion cases are somewhere in the middle.
Yeah, I like to intervene, Anjali, because look, there is a conflicting data. Some of the earlier data said that the PAX7 were better, but overall, for now, and what most of the gurus take into account is that all PAX fusion 3 or 7 are poor prognostic. And now, very soon, we'll have addition of Myo D1 mutations as well as TP53 to this. But for now, only these fusions.
Thank you, Dr. Mashmi. So coming back to you, Dr. Manas, for this child, an NGS panel was sent and he was found to be fusion negative. So the final diagnosis, or we'll say that finally the child was treated as a non-metastatic embryonal rhabdomyosarcoma intermediate risk. So what will be your risk-adapted approach?
Can I just comment on this, doing a NGS for this patient? I just wanted to comment that if we do a FISH-based or a PCR-based analysis for PAX3, PAX7, I'm not sure if the cost-wise, this thing would be a bit cheaper than the NGS, unless yes, you are doing on some kind of a study base. But I'm not very sure, and maybe Dr. Mashmi can enlighten us that if FISH PCR can replace NGS-based analysis for PAX3, PAX7.
Yeah, I'll answer that. But before that, I have one thing. So the initial diagnosis was alveolar rhabdomyosarcoma, right? And now it has come out to be embryonal rhabdomyosarcoma. So these are two different things. So we need to clarify. So what are we dealing with? And in alveolar, almost 90% of them are FOXO fusion positive. So there is still a 10% chunk which is alveolar, but it is not FOXO fusion. Okay, but then we need to be sure on that. So what are we dealing with? Either we are dealing with embryonal, which generally have a very good prognosis compared to the alveolar, if other factors are taken from histological point of view. So that is one thing. And just looking at FOXO fusion, yes, of course, FISH will be cheap, easy, everything. For now, this is good. But eventually you might need something like a NGS to.
Sure. As the science develop, maybe NGS has more to offer in this. I agree.
Yeah, actually, presently a lot of data is available. So big institutions are already doing those things.
Sure.
So, but for now, yes, it makes sense just to do FOXO.
Okay. So coming back to the question that Dr. Anjali had posed to me was on the approach of managing this patient. So she has mentioned that it is a non-metastatic. So that means the metastatic workup has been done. And let's take it that it was an alveolar head and neck kind of a disease which has been removed piecemeal. And there may be a tumor spill. So at this point of time, we have to go ahead and risk stratify this patient. So we are all aware that there is a IRS staging, then there is a grouping, and then you finally kind of assign the risk stratification for the patient. And when you look at such a patient where the tumor has not been fully removed, that means the gross residual disease is present. I'm assuming that that is what the whole tumor spill and the tumor being there is kind of trying to imply. So if you say that there is a gross residual disease left and a surgery was done at a non-oncological intention, then you would be left with a group 3 disease in a parameningeal location, which is an unfavorable location for a young child. And this would kind of fit into an intermediate category of final risk stratification, and we would have to treat according to that.
So this child was started on VAC-VI based arm of the ARST 1431 protocol. which included vincristine, actinomycin D, cyclophosphamide, and irinotecan. So the reevaluation contrast MRI was done at week 12, and there was complete response on imaging. Now, Dr. Nehal, can we have you here? This child has been referred. Hi. This child.
Hi, hello.
Yeah, Dr. Nehal. So this child has been referred to you for radiation now. To summarize, the child is now 1.5 years old, being treated on the lines of embryonal RMS, or let's say fusion negative alveolar RMS, parameningeal site, after a non-oncological resection with complete response on imaging after induction chemotherapy. Will you consider omission of radiation as an option here?
Am I audible?
Yeah.
I would like to first thank you, Dr. Anjali, Dr. Jaskaran, and Dr. Gauri for inviting me. This is a very relevant question here because the child is so young and it would concern all of us. But it is not a very difficult question to answer. What I would like to know is, was an imaging done post-op before starting induction chemo to see what was the residual disease here?
Yes, I have not put it up, but when the child had come here, a PET-CT was done, and that did not show any uptake at the site where initial CT had shown the lobulated mass.
Okay, so what I can understand is this is most likely a group 2 disease, what we are looking at, an alveolar histology, but fusion negative. So we have, some good things here, some bad things here. If this was a group 3 disease, I'm sure you would not even have asked this question whether we can omit RT or not. In a group 3 disease, we know that the local treatment for parameningeal site is radiation. When we look at a group 2 disease, wherein a gross total resection has been done and microscopic disease is left behind, just as in this case, we know as per the guidelines that even for embryonal histology, we will have to give adjuvant RT. Not adjuvant RT, but definitive RT. If at all this patient was operated upon by an oncologist and they would have got an R0 resection, considering this was a group 1 disease. I'm just taking it, step by step to give you a better perspective. If this is a group 1 disease, but because it's an alveolar histology, though fusion negative, there is still an indication of RT. We cannot avoid RT in this child.
So what would be your...
Can I just intervene? Like from his molecular point of view, if it is a alveolar RMS and it is fusion negative, it will behave like embryonal. Its prognosis will be like embryonal. This is what...
Very
from
important
molecular.
point.
I'm not saying the other factors, but only molecular.
Yeah. So Dr. Moshami has actually brought forward an extremely important point here. So this is actually debatable in fusion negative but morphologic alveolar. And there is in fact a phase 2 study undergoing. If I remember correctly, it is ARST 1431, in which they are evaluating omission of radiation in group 1 alveolar RMS FOXO1 negative.
So
but this is in a trial setting. For this patient, even if it is a group 1, I would recommend adjuvant RT because it is alveolar.
Yeah, I think the guiding factor for us over here is a parameningeal site and a non-oncological.
Exactly. It's an unfavorable site. It's a young child. It is a poor prognostic histology.
Yeah. So what would be your total dose and volume like?
Yeah, so if we go by COG, COG recommends for group 2, especially in this case, when nodes are not involved, the dose of 36 gray. Dr. Jaskaran also mentioned that. I would say any dose between 36 to 41.4 is the ideal dose here. If we take this question of fractionation, conventional fractionation is the standard of care. If you all remember in the IRS4, it was a randomized study wherein hyperfractionation was practiced and 1.1 gray twice a day was given with a very logical concept that in children we want to avoid late side effects, and all radiation oncologists, we all know that lesser dose per fraction leads to lesser long-term sequelae. But neither did this trial showed any improvement in outcome. In fact, acute toxicity was much more. This was from the Sarah Donaldson group. So I would recommend conventional fractionation doses between 36 to 41.4.
Okay. So, Dr. Punita, ma'am, what are the organs at risk that you would consider for contouring in this child?
Yeah, hi. Thank you, Anjali, and thank you, Jaskaran and the RGCI team. Yes, that is a very important thing, because like what Nehal mentioned, it's a child that we are talking about, a small child, and we are going to face these long-term sequelae at a later date once he becomes all right, and if he's cured, which is a good chance going by his histology and other features. There's a reasonable chance. So we really have to look into the structures that are sitting close by, for instance, the eye, the optic apparatus, the face and the muscular bones, and the dentition, especially the secondary dentition. All these need to be factored in. Plus, because the beams, that we have to look into the trajectory of the beams, and if the beams are going to pass through, say, areas such as the parotid glands and the salivary glands, then that also becomes important from our point of view. Yes, it is a modest dose, but then areas which see, modest dose would have lesser long-term sequelae. At the same time, we cannot avoid the idea of second malignancy also coming into play at a later date. So we have to look into that as well. So these are factors we have to be prepared that there might be facial asymmetry at when the child grows up, or the dentition might be, he might have carious teeth, the eye vision, all needs to be looked into.
Thank you, ma'am. So for this child, we contoured the GTV after registering with the baseline CT, cropped it from the air cavity, and got the final gross tumor volume. The CTV was generated by giving a 0.5 centimeter isotropic margin. However, we decided to contour the entire pharyngeal wall in the initial volume of 36 grays because there was a tumor spill, and then CTV2 was generated over the final GTV. So this child was planned up to 50.4 grays in 28 fractions using IGRT VMAT technique. There was a long list of organs at risk, including the unossified cervical spine, because this was a paravertebral location of the target volume. Most of the constraints could be met easily, including the maxillary dental roots, the ossification centers, most importantly, the spinal cord and the thyroid gland. Dr. Punita, any take on the maximum, the hotspots that you would allow and the minimum coverage that you would like to have?
Hello?
Yes, ma'am.
Yeah, could you just repeat your question?
Ma'am,
wasn't clear.
while evaluating this plan, what is the maximum, the Dmax that you would allow, and any other pertinent issues that you would address while evaluating a plan for this child?
So we would look at the based on the ICRU report, we would, and especially for a pediatric age group of this, we would look into the uniformity of the dose that the PTV is receiving, and whether the 95% is getting 95% of the dose. So that would give us uniform coverage of the PTV that would be drawn. And as far as the organs at risk, which you have shown the DVH, we would look into all these organs at risk and try to keep the dose constraints within limits as per the Quantec this thing criteria. So most of them would be anywhere between, I would say, 20 and 30 gray, and we need to follow the contact to the letter.
So after 3 months of completion of the entire therapy, including the adjuvant chemo, the child just sometimes presents with on and off noisy breathing. There is no palpable mass. The growth of the child is within normal percentile. An MRI that was done 3 months post completion of treatment showed some edematous changes in the irradiated area, and the thyroid profile remains to be normal. So, Dr. Vineet, if this child is now to be given, the parents have to be given a schedule for follow-up. So what would be your follow-up schedule with respect to disease status and any long-term adverse effects of the chemo agents that have been given in this child?
So a very good afternoon, everyone, and congratulations to the Pediatric Oncology and Radiation Oncology team for organizing such a wonderful academic session. So, ma'am, coming up for the first question, the follow-up schedule with respect to the disease status. So, for the first 2 years, I would advise a 3 monthly follow-up of the patient with the local site MRI. However, considering a repeat MRI in on such short notice would of course be a bit tough. So, but if we really go theoretically, a 3 monthly follow-up with a local MRI would be present. Most of the recurrence or relapses in RMS are 90%, I'll say, are within the first 2 years. And then they are very rare after that, 9% after 5 years as per the data. So in the second and third year, the follow-up would be 6 monthly. And in the fourth and fifth year, I would, annual scans would be done to look for any disease recurrence in this case. Coming to the second one, the long-term adverse effects, ma'am. As Dr. Punita already mentioned about the radiation, so combined chemotherapy and radiation side effects, I would be worried about. So, if we see the short stature and the facial asymmetry would be the most common ones. Secondly, the dental delay, the delayed dental eruptions, the abnormal dentition would be my second thing to see in this child. Also, as we are giving alkylators, the cyclophosphamide, so I would be concerned about the infertility issues. So in follow-up, I would do annual tanners up till the pubertal age of the child. Second cancers would be delayed maybe after 7 to 10 years, but I would keep the probability of secondary malignancy in mind. Then endocrinopathies, because pituitary radiation would be present. So at pubertal age, growth hormone or hormonal analysis plus growth velocity monitoring would be present yearly as the child follows up to me.
Okay, Dr. Vineet, thank you so much. I'll have to wrap up for paucity of time. So far as the radiation is concerned, we are concerned of his hypothyroidism. This child will have towards hypothyroidism. So we will advise.
Anjali, can I make a point? Anjali,
Yes, sir.
sorry, just a comment to this. Not all the parameningeal site we say are no go for surgery. There are certain parameningeal sites which are amenable for surgery, like the sinuses, the maxillary sinus, or the ITF. Even this hypopharynx or the oropharyngeal region, I would say the thing I would have done differently in this child would have been instead of a complete excision or attempt for an excision from the initial part, we would have done a direct laryngoscopy, chart out the extent of disease, do a biopsy. There may be diseases other than rhabdomyosarcoma. We have encountered IMFTs in the oropharynx, and then we have to do surgery. But when we have a rhabdomyosarcoma, this is again amenable for surgery in the sense we could have given chemotherapy first, delayed surgery could be done, and you could have very well done a complete excision. And the question of radiation, because everything except for the site is appearing unfavorable in the sense that the FOXO gene is negative. It is a fusion negative and it will behave as Mashmi said, it will behave like a ERMS only. So there could have been a place for no radiation if the surgical excision would have been complete. And this is easily resectable in the sense a lateral pharyngeal wall excision with or without reconstruction could have been done. So that's what different I would have done. The last comment I want to make is that how do you follow residual disease after your completion of treatment? There is some residual thing which is not lighting up on the PET scan. How do you manage that? Jaskaran, this could be for you also in the bladder, in the sinus, in the ITF, where a non-surgical local treatment has been given.
So if scopies are possible, then we would like to have a biopsy from these areas from a surgical oncologist to guide us better. Because many a times imaging actually does not give us the true representation.
Most of the time, I'll give you the report. Most of the time, the biopsies are rhabdomyoblast or a residual disease or only fibrosis. And again, we are left with this question: how do we manage this? This is a very frequent problem we face with our bladder. And we have realized that it is not always the disease. Even when we have histology, which is saying it is a rhabdomyosarcoma, we have observed some of these patients. And to our surprise, it was only the responding or the rhabdomyoblast which were not going to be a residual or recurrent disease. So it has to be taken not with a pinch, but rather a fist of salt when you have residual disease and which is not being picked up by nuclear imaging, which is biopsy is not being helpful, or biopsy is not possible because of the different difficult access. So a clinical decision in that situation could be more judicious rather than frantic attempts at getting a tissue diagnosis or getting some nuclear imaging to know the viability status of that disease.
Yes, so
I agree with you, sir. Observation at times is very important.
Thank you, Dr. Sajid.
Yeah, and thank you, everyone. That was a
Thank you, everyone.
Thank you. Thank you very much.
Yeah. And now,
thank you.
Thank you. And now I think let's move on to the next session. And I would request Dr. Payal to kindly take over and coordinate the session. Dr. Payal, you there?
Yes, sir.
So please go ahead.
So now let's come to the last session of this beautiful winter evening, which is on Ewing sarcoma. And for that, I invite our chairpersons, Dr. Manish Pandey. Dr. Manish, who is a senior consultant, radiation oncology at Action Cancer Hospital, New Delhi. And Dr. Manish Puruthi, who is an assistant professor, orthopedic oncology at TMH Mumbai. With your permission, sir, I would like to invite our speaker for this particular session, Dr. Siddharth Laskar. Dr. Siddharth Laskar, he is professor, Department of Radiation Oncology at Tata Memorial Hospital, Mumbai. So the topic for today, the expert lecture is dose escalation of radiotherapy in Ewing sarcoma. Over to you, sir.
Good evening, everyone. Thank you very much. Congratulations to the RGCI team for completing 25 years and going strong, and best wishes to you. The topic for my talk is a definitive radiation for definite radiation for treatment of Ewing sarcomas. Now, radiation therapy, as all of us know, has been very effective in the treatment of Ewing sarcomas. And this data comes from a very long back, way back in 1950s, where good disease controls were achieved with radiation therapy alone. And in this study from the Mass General Hospital done in the 50s, the local controls with radiation at the end of 5 years was 89%, which is very high even by today's standards. But what I want you to notice in this summary of the publication is that at that point in time, majority of the local treatments would be done using radiation therapy. And in this study, it was 72%. And the other interesting thing was that there, even at that point in time, they were looking at dose response relationships in Ewing sarcomas in order to find out the most optimal dose for curative radiotherapy. Now, the policies for treatments have evolved over the years, and as expected in the early times, when radiation alone was the treatment of choice, one would treat these patients with high dose radiation. The volumes of radiation would include the entire organ or the entire bone, and the doses of radiation also would be relatively high. But as we understood the natural history of Ewing sarcoma better, in terms of the failures in distal sites, there came the role of chemotherapy, and multi-agent chemotherapy prior to local therapy became a standard, and that made a huge difference in local control and survivals of Ewing sarcoma. So based on that, the radiation therapy volumes, radiation therapy doses, and the indications also evolved. We will discuss about some of them as we go on with the talk. The other thing that influenced treatment, the local treatment specifically, were the developments in surgical techniques and prosthesis, because of which the use of radiation therapy gradually went down as the local treatment modality. So currently, the standard of care would be neoadjuvant chemotherapy, followed by local treatment, either in the form of surgery, radiation, or a combination of surgery and radiation, and followed by maintenance therapy. Now, it is important to look at the demographics also. That is because it tells us a little bit about what age these people come with. They are relatively young. Almost 65 to 70% of these patients are in the second decade of life. And the other important thing that one needs to note here is that the site of disease involvement. In majority of them, the disease involvement would be in the pelvis and the centroaxial skeleton, and a significant proportion of them would also involve the extremities. Now, why is it important? Because the technicalities of treatment and the possibility of adverse effects of treatments are all influenced by where the tumor is located, and also the ease of doing or the technical specialization that is required for these areas would differ based on which area the tumor is located in. Now, having said that, there have been large cooperative group trials that looked at and tried to refine the treatment over the years. And some of them I have just enumerated here. If you look at the IESS studies that were started in 1970s, to the more recent ones in the form of Euroiving or the COG studies, the local treatment in the form of surgery has been in about 40% of patients. And the remaining patients would either be treated with radiation therapy alone or a combination of surgery and radiation therapy in patients who had poorer disease related factors seen during surgery. Now, when we look at outcomes, we do compare the outcomes in terms of what the local treatment has been. And radiation therapy, as you know, is one of the local treatment modalities. And what is also known over the years is that the outcomes of treatment in terms of local control and even possibly survival have been inferior in patients who've been treated with radiation therapy. That, as most of us would agree, is not a reflection of the efficacy of radiation, but probably, or it's actually the reflection of the negative selection bias for patients who receive radiation therapy. Now, looking at the failure rates, when you compare surgery, radiation, and a combination of surgery and radiation therapy, you would notice that the failure rates are in the range of about 25 to 30% if you are treating with radiation therapy alone. But if you have surgery as the local treatment or a combination of surgery and radiation, the local failure rates are in the range of 7 to 10%. So you have about 15% advantage if you are doing surgery in these patients. These needs to be kept in mind when we are deciding between a patient to be treated with definitive radiation versus a surgical modality. But surgery is also associated with functional deficits, and most studies have shown, and we know very well, that the functional outcomes of patients treated with radiation alone in the short term is much better compared to that with surgery or a combination of surgery and radiation. So these factors need to be kept in mind while we are deciding the best choice for local treatment. Now, this is important data that has come from the ICAS group, and this is possibly the largest database available of outcomes of patients treated with relatively recent and standard treatment protocols. And in this large database, it is important to look at what happened to local disease control, to second malignancies, and also other distant metastases between patients who were treated with surgery alone vis-a-vis patients treated with radiation therapy. And if you see, what is very striking in these outcomes is that what is clearly different is the difference in local control. Obviously, patients treated by a combination of surgery and radiation therapy did better compared to radiation alone. But what was not really different were the incidence of distant metastasis or the incidence of second cancers. So again, when we are discussing in our clinics to decide which is the most appropriate treatment, and when we discuss about second cancers, we need to keep in mind that it is not very different. Although we know that radiation does predispose the patients to cancers in the long run, but what you need to understand is that the data shows that it is not hugely different. So that's where we need to strike the right balance between the risk of second cancers versus disease control and functional outcomes. Now, broadly, this is again showing a similar kind of outcomes data. If you treat with radiation therapy alone, the local controls of 25% approximately, whereas if you treat with either pre-op RT followed by surgery, or surgery followed by post-op RT or surgery alone, the recurrence rates are in the range of 5 to 7 to 10%. Another important thing that was seen here is that if you're doing surgery, the volume of the tumor does not remain an important prognostic factor. But if you're doing definitive radiation therapy, the volume of tumor becomes an important prognostic factor. And the cutoff that they have seen in these studies is that a volume more than 100 cc actually has a negative impact on local control when you use radiation. So the problem is that most tumors in our country would have volumes more than 300 cc. So majority would lie in the poor risk group. So we need to do something by which we can address these patients who are inoperable at the same time have large volume disease. This is the same outcomes chart showing that definitive RT results in inferior outcomes compared to surgery followed by RT. We know that by reducing the volume of normal tissue that we radiate, there is a possibility to reduce the acute and late side effects of radiation. And this becomes very important in children because they are prone to the side effects of radiation in normal structures. So it was important that the group from Stanford did this study, the POG 8346. What this study really looked at was to randomize patients to whole bone radiation or the whole organ radiation versus involved field radiation. That means the tumor with margin, which had smaller volumes. And the results showed that there was no difference in the event-free survival between patients who received whole bone radiation versus the tumor with margins. And that was the basis for tailored portals in Ewing sarcoma. And this obviously led to the thing of reducing volumes and reducing the possibility of side effects. People from St. Jude and other centers in the US were also looking at how radiotherapy doses could be optimized for patients who are having large tumors, more than 8 centimeter, versus smaller than 8 centimeters, and compared also with patients who had surgery as their primary modality of treatment followed by post-op RT. What was reported from this study, although this was a non-randomized trial, is that children with tumors more than 8 centimeter in the maximum dimension would benefit with radiation doses of more than 64 or 60 gray. So what they said was 64.8 gray resulted in better disease control compared to patients who had 55.8 gray, which is considered as the standard of care. And the post-op patients who had microscopic disease did well with 50.4 gray. So there was some indication on what the optimal dose of radiation would be for gross disease, for large disease, for small disease, and for microscopic disease from this study. Now, the COG in this report, which is more recent, looked at the outcomes and the factors that influenced local failure. And again, as expected, the important factor that defined local failure was the treatment modality. And patients who were treated with radiation alone had inferior outcomes compared to the ones who were treated with surgery followed by radiation. Now, this was again because of a selection bias of negatively selected patients in the radiation group, which I will show you in the next slide. The other important thing that was visible from this analysis was that it was not only the volumes, but it was also the site, the location of disease. And what was clearly seen from this study from COG is that patients who had centroaxial disease had inferior outcomes compared to patients who had disease in the extremities. And this is obviously because of the ease of doing treatment in the extremities compared to the centroaxial skeleton. So this is probably the reason why it was seen that radiotherapy is not doing well. If you look at the columns where of radiation, and if you look at the site, 50% of the patients treated with radiation therapy had disease in the pelvis, whereas half of that number was actually treated by surgery. And similarly, spine, almost 63% of patients in the spine had received definitive radiation therapy. So obviously there is a negative selection here, and that's the reason why radiation seems to be doing poorly. Now, besides those factors, there are other factors also that influence the outcome of radiation therapy. And this is important for the radiation oncologist. And if you see on the left side of the slide, it shows the volumes. And if you see, the smallest volumes of tumors were treated with surgery or a combination of surgery and radiotherapy, whereas the larger ones were all treated with radiation therapy alone. And as I said in the beginning, volumes do have an impact in the outcomes of treatment when you're treating with radiation therapy in terms of local control. The other important thing, especially for the radiation oncologist here, is the quality assurance. In this study from the German group, it was seen that good quality assurance did have an impact on disease control. Now, that was for most of the extremity and the centroaxial skeleton. Another major difficult area is the chest wall, and sometimes surgical resections become very difficult. And as you can see from this study from the ICAS group, only 12% of the patients were treated with surgery alone, whereas the remaining patients had to be either treated with definitive radiation therapy or a combination of radiotherapy, surgery, and radiotherapy because of the technical difficulties. And this is a challenging area, and it is difficult to achieve good local controls because of the technical difficulties in treatment. We had our own study, and we also showed similar outcomes as the ICAS group. And our major challenge was to deliver optimal doses to the target volume, because these volumes are extremely irregular, and they can be huge, and they could have very critical structures lying close to the tumor bed. A similar outcome was seen in the Euro-Ewing trial also. So as a standard now, we follow the same policy as we use for the extremities. What about head and neck tumors? There is not much data available, published data, but most data shows that the treatment protocols for head and neck Ewing sarcomas should be in the similar lines as the extremity or the chest wall Ewing sarcomas. And this is data from AIMS, where they showed good local controls, which were superior with radiation alone, which was surprising compared to the ones who had surgery and radiation therapy. And this is just to show some pictures which are the patients who actually receive definitive radiation therapy, like the big pelvic tumors or large chest wall tumors, where it is with multiple critical structures nearby, and hence treatment becomes very difficult. So what are the options do we have for these patients where surgery cannot be done? One, you can possibly escalate the dose using highly conformal techniques that you have. Number two, you can possibly do particle therapy in the form of protons or heavy ions. And this was the basis for our study of Ewing sarcoma radiation dose escalation. And we hypothesized that for these patients who had unresectable disease, we could improve local controls by escalating doses to 70.2 gray instead of 55 gray. And we analyzed their outcomes. This was a randomized controlled trial, and we have long-term data now, and this paper is currently under publication. Soon we'll have the results out. But just to tell you, the local controls did improve to 76% in escalated dose, whereas the local controls were 59% with standard doses of radiation. And there was an indication of improvement in the overall survival also in the patients who received escalated doses of radiation. The other modalities, the new kid on the blocks, is particle therapy. Protons have the ability to spare normal structures better, and hence you may be able to escalate doses to higher levels. But besides that, there may be also some biological advantages of using protons, and obviously definite advantages of using carbon ion. Although we do not have much data in pediatrics, but in the adult age group, we do have data from Ewing sarcomas treated with proton therapy from Mass General Hospital and PSI, where they have reported short-term local controls in the range of 80 to 85%. This is data from Paul Scherrer Institute in Switzerland. Again, they have reported local controls of 81% at 5 years with definitive radiation therapy. So is proton therapy actually better than X-rays? In terms of local control, at least we do not have data currently to show that they are significantly better, but there is data coming in which shows that because of the better sparing of normal tissues, there is lesser toxicity in the patients treated with proton. And this is small outcomes from a consensus meeting that we had on the use of proton therapy. And as you can see, there was a question to the experts here of the choice of treatment for these various pediatric tumors. And for Ewing sarcoma, as you see, most would recommend the use of protons, but there would be a significant number who would also recommend photon beam therapy. So to answer the question whether proton is better or photon, it would depend on what location the tumor is and what is the status of the primary disease, whether it is post-operative and what the dose you are trying to do. We are all worried about side effects of treatment, and we keep looking at data to see how radiation does affect treatment-related side effects and second malignant neoplasms. But if you look at the long-term data from this systematic review on Ewing sarcoma specifically, the second malignant neoplasms were in the range of 7 to 8 at 7 to 8 years was about 8%. and which would increase to about 20% in the long run. But they are mostly in the form of AMLs and myelodysplastic syndromes, which probably is not only because of radiation, it's probably a combination of chemotherapy and the radiation treatment. So that needs to be kept in mind when you're deciding toxicity and discussing toxicity and second malignancies. Similar data, but this is not for Ewing's, but overall, there seems to be some advantage of using protons over X-rays in terms of second malignancy, but this is currently not significant, and we need to have still a robust data. This is data from the Japanese group where they looked at long-term outcomes and the benefits of proton beam therapy. It looks like there are no in-field malignant transformations, at least in the currently available data. So that is good news, because there was a worry amongst people that would particle therapy increase second malignancies in the field of treatment. And then finally, for the radiation oncologists here, what are we trying to do? What has been seen to be significant is the integral dose of radiation. So do not get carried away by IMRT alone. It should be conformal radiation therapy with a low integral dose that is going to influence the development of second cancers. So whenever we are doing our IMRT plans or conformal plans, we need to keep in mind this factor of integral dose, which would possibly be the factor that would reduce the chances of second cancers in the future, which is the worry with most radiation therapy treatments. And finally, this slide I keep showing that, please do not think that radiation is the worst one for the child in terms of local treatment, because they lead to second malignancies. But this data from the Children's Oncology Group shows that the second malignant neoplasms that develop in these long-term follow-ups in specifically Ewing sarcomas and osteosarcomas is not a great difference between what we see with radiation vis-a-vis etoposide and cyclophosphamide chemotherapy. So to summarize, radiation therapy contributes significantly to the local control in Ewing sarcomas. Almost about 30% of patients with the Ewing sarcomas would receive definitive radiation therapy, and possibly another 30% would receive post-op adjuvant radiation therapy. So it does form a significant component of the local treatment that's radiation therapy. Now, it is challenging to deliver optimal doses. You need a nice technology. You need to have the know-how regarding the target volumes and the organs of risk. High precision radiotherapy and newer therapeutic modalities in the form of particle therapy has been shown to be useful, although not in terms of local control, long-term local controls, but definitely in terms of toxicities. And although there is an increase in second malignant neoplasms in patients receiving radiation, but it needs to be kept in mind that you need to balance between the toxicities versus disease control versus the functional outcomes. So integral dose, as I said, is again an important factor that would possibly help in reducing the second malignant neoplasms with definitive high dose radiation. So thank you very much. That's all I have, and I'll stop at that. Thank you.
So thank you, sir. I think it was a very exhaustive and a detailed yet a very comprehensive presentation. I would now request our chairpersons for their expert comments, and please to take questions in chat box if any.
Is Dr. Manish Pandey there? I guess he's not here. So thank you very much, Dr. Laskar, for an excellent presentation. It was very informative. So I have like a few questions to you, if you allow me to ask. So there are two scenarios. Like the first thing is, if you have a case of an axial Ewing sarcoma, like in pelvis or in spine, would you always consider a dose escalation versus a standard dose? And second thing, now with an availability of protons, which is coming now in many centers, would you consider these cases for protons over photons? These are the two questions that I would like to.
So the to answer the first question, will I always prefer radiation? Is the first actually should
No,
be
no,
the
no. Will
first
you
question.
always prefer the higher dose of radiation?
If we are not operating.
If we are not operating, definitely,
Okay.
like we have already thought of it, we are treating with
Yes.
definitive radiation.
Okay. In that case, we have shown that we should, and we would now. Currently in our hospital, we are still sticking to 55 because the paper is not come out. So the moment our paper is there, we will change our protocol to 70 gray.
Okay, sir. Thank you.
So that's the first one. And then there was a second question also.
Second thing is, like with an availability of protons now at many centers, will you consider protons over a higher dose of photons if you are treating with definitive radiation?
So, as I showed, in terms of local control, there is not much difference between protons and photons. But in terms of toxicity, possibly there is. So depending on what site that I'm treating, I would triage my patients to protons. So in a way, what I'm saying is that we would probably look at the dose volumes, plannings, and see whether doing proton gives me any kind of dosimetric advantage. Because the dose that I'm delivering is the same, either we do with protons or photons is the same. So I'm not looking at a difference in local control, but I'm looking at a difference in toxicity, but only if there is a significant difference in the dose profile to normal structures, we would prefer protons.
Just asking another question on dose profile, sir. Can you offer a better dose profile in a spinal Ewing sarcoma with protons as compared to a photon? Because the dose of photon we can not cross usually 45 grays when it's a paravertebral or a vertebral Ewing sarcoma. Can we offer a better dose with protons there?
So even if we go by the escalated doses, if we consider that as standard, and if you want to deliver 70 gray to your tumor, you, depending on where the tumor is located, you may be able to restrict the dose to the spinal cord to 55 gray. But yes, your ability to spare the spinal cord would theoretically be better with protons.
Thank you very much.
Sir, there is a question in the chat box.
Yeah. So Dr. Laskar, there is a question like, is there any role of altered fraction instead of just of dose escalation? This question by Dr. Imtiaz Ahmed. Yeah.
So we really don't have data or to say whether hypofractionating does help in Ewing sarcomas. We really don't know that. The only thing that we know now is that yes, if you increase the dose a little bit, there may be an improvement, which has come from our study. But we really don't have data to say whether this escalated dose can be delivered effectively in a hypofractionated manner, like we are doing in prostate. So maybe as we are using carbon ion and protons tomorrow, we may, instead of giving 2 gray per fraction, we may end up giving maybe 3 gray per fraction. So, but we really don't have data on that.
So I guess there are no further questions.
Yeah.
So, yeah. Thank you very much, sir. So Payal, you
Thank
can,
you.
Thank you very much, sir. Payal, you can proceed with the next session.
Okay, sir. So now going on to the next session, which is improving outcomes for non-metastatic Ewing sarcoma, a case-based discussion. This will be a panel discussion. And now I invite our moderator, Dr. Himanshu Rohila, who is consultant orthopedic oncology at Rajiv Gandhi Cancer Institute. And I also invite our light panelist, Dr. Akshay Tiwari, who is Director Musculoskeletal Oncology at Max Institute of Cancer Care, New Delhi, Dr. Munlima Hazarika, who is Professor and Head Medical and Pediatric Oncology at Assam, Dr. Manoj Tayal, who is Senior Consultant Radiation Oncology at Medanta, Gurugram, Dr. Upasna Saxena, Consultant Radiation Oncology at CG Cancer Institute, Mumbai, Dr. Vivek Mahavar, who is Consultant Radiology at RGC and RC, and also myself, I'm Dr. Payal, I'm Consultant at RGC and RC in Pediatric Oncology Department. So over to you, Dr. Himanshu.
Thank you, Dr. Payal, for the introduction, and thank you, Dr. Jaskaran, for the opportunity. Can I start sharing my screen now?
Yes, please.
Is it visible?
Yeah, it's visible.
Okay. So we'll go straight forward for the case. So this is a 18-year-old male who presented in a year of 2012 with pain and swelling in the left pelvic region for last 3 months. We don't have the x-rays available from that time, but we do have the MRIs. Can I ask Dr. Vivek to comment upon this MRI picture? Dr. Vivek?
Yeah. Can I audible? Am I audible?
Yes, sir. Yes, sir.
Yeah. First, I like to thank and congratulate Dr. Jaskaran and Dr. Anjali and Pediatric Oncology team of our RGCI for such a nice meet. Here, in this MRI, I see a bony lesion, altered marrow signal intensity bony lesion that is involving left iliac bone, acetabulum with large associated soft tissue mass on both sides of the bone.
So, sir, primary bony neoplasm?
Yeah. I will go for the primary bony neoplasm because soft tissue is seen in both sides of the bone in this scan.
And would you prefer any other alternate imaging with this, like a contrast enhanced MRI or a non-contrast? Do we always need a contrast MRI?
We usually prefer contrast enhanced MRI in all these cases because they not only helpful in the surgical planning later on, but also if this is a malignant mass and we give the neoadjuvant therapy, for the response assessment is better if we have the pre-treatment contrast enhanced MRI later on.
So does it help, because anyhow we are doing the biopsy? So in terms of doing a contrast lens, whether it's an infection or a neoplastic lesion, can we skip the contrast?
Yeah, we can, but later on, if we give any neoadjuvant treatment, then if we have the pre-treatment MRI with contrast imaging, then it improves the response assessment later on in the post-treatment MRI.
Okay, sir. So from your opinion, it would be a primary bony neoplastic lesion with extensive soft tissue component.
Yeah.
Okay, sir. And differentials?
Because this is a small child, the differentials are obvious, like Ewing sarcoma or some hematological malignancy like lymphoma.
Lymphomas. Okay, sir. So we did a core needle biopsy, which was suggestive of Ewing sarcoma, positive for CD19 and Fly1. In 2012, we did not have an NKX 2.2, so Fly1 used to be done, and negative for LCA, Desmin, EMA, and synaptophysin. Staging investigations were done in form of CT scan of chest and bone scan, which was suggestive of non-metastatic presentation. A bone marrow biopsy was done, which showed an uninvolved bone marrow. So my next question is to Dr. Payal. What is the role of PET in staging of Ewing sarcoma in the current standards? And do we always order a PET, or what is the indication to order a PET scan?
Okay, so in staging of Ewing sarcoma, we need to see two things. One is the local spread of the disease, and the second is metastatic spread. So for that, from the ancillary time, we've been doing CT chest, bone scan, and bone marrow, because these are the three important sites of metastasis, lung being the most common. And for last few years, we've been doing PET scan, as PET scan can replace all three of them. So yes, for staging, if you do a CT chest, bone scan, bone marrow, it is okay. And if you do a PET scan, that is also okay. I see the second question, which says if a marrow examination is mandatory, and if
Dr. Payal, can we just, before going to the second question, can we involve from radiation nuclear medicine department, how confident they are to pick up a marrow met on a PET scan? Is there a radiation oncologist or nuclear medicine?
We don't have it on the panel, Dr. Himanshu. But
okay, so can you?
Yes. So if we review the literature, and if I look at the Western, especially the Western literature, so they are doing PET MR. Okay, so they are doing a whole body MRI with PET scan, and that definitely has a very, very good sensitivity to pick up with bone marrow lesions. Okay. PET CT, I would say there is a gray area wherein you may some people are not doing bone marrow aspiration biopsies, and some people are doing. But with the PET MR, definitely it can be skipped. PET CT, we would be a little skeptical, and we would want to do a bone marrow aspiration and a biopsy. And this is what we practice in our center as well.
Okay, so in your opinion,
this is Dr. Manoj here. I would like to comment on this.
Yes, sir.
The thing is, with PET-CT also, you can pick up marrow infiltration as well. And it becomes more important. Suppose if there are no other bony mets other than the primary lesion itself, then you can very much easily avoid doing a bone marrow examination as well, because the chances of a bone marrow infiltration in a negative PET in bony lesions, so the chances of picking up the marrow lesions also becomes important. So I don't think it is really important to do a bone marrow examination if the PET-CT is not showing any bony lesions.
So I think I agree with Dr. Manoj to have isolated bone marrow metastasis and Ewing sarcoma without a without bone mets or without lung mets is very, very rare.
I'm coming to that. Yeah, so if you look at isolated bone marrow metastasis, also the incidence is around 11%.
Yeah.
And that also is more in patients who already have a metastatic disease.
Correct.
So yeah, so you can pick up marrow lesions even in PET-CT also. So in a negative PET, if you don't do a bone marrow examination also, I think that will suffice.
I'm Dr. Upasana here. I'd like to just add that even in fact, as per the recent ESMO guidelines, it says the same, the 2021 guidelines, that if we have a PET-CT that's not showing a marrow involvement, we can actually omit doing a bone marrow biopsy. So
yeah, I agree. I think most of the centers do not do, but I just said that PET-MR definitely has a better sensitivity. PET-CT, a lot of papers, a lot of centers, they don't do, but at our center, we still practice doing the bone marrow aspiration biopsy.
Dr. Payal, another question which I would want to ask you, if you're doing a whole body MR,
yeah,
do you really want to do a PET scan to stage patient again?
No.
So why a PET scan with a whole body MRI?
Then we don't do a PET scan.
So if you're doing a staging investigation, which is a whole body MRI,
yeah,
then also we don't need a bone marrow.
No. Definitely MRI has got a very good sensitivity for picking up marrow lesions.
So do you want to replace a whole body MRI for staging in a Ewing sarcoma?
So this is, I will tell you something. This is not the standard of practice. These are only few papers which have come recently wherein people are trying to do whole body MRI as a standard of practice. You do a PET-CT with or without bone marrow. That is definitely plus minus. As we can see amongst the panelists also, all of us have different opinions. However, if you're doing a bone marrow or not doing, I think both are justified. Doing a whole body MR is still not standard of practice. You either do a CT chest marrow with a bone scan or a PET-CT, plus minus bone marrow.
Okay.
So Himanshu, if I can come in here.
Yes, sir, please.
Yeah. So basically, like as far as the whole body MRI is concerned, it's a very time consuming procedure. And usually most of the centers are not able to do whole body MRI because it requires a lot of time. Second thing, most of the patients are pediatric, as Dr. Laskar has shown. Almost 65% of Ewings happens in less than 18 years of age. So it is very difficult to keep a child still for next 4.5 hours for a whole body MR. So most importantly, for our staging, we are doing a PET-CT and it has a very good sensitivity or a very good, you can say, negative predictive value. If PET does not show a bone marrow metastasis, we can more or less rule out a bone marrow metastasis. And if PET shows something in a bone marrow, then definitely we need to confirm it further by either doing a bone marrow biopsy or doing an MRI of that area. Because PET as a specificity could be less, but the sensitivity is very good. So only a PET-CT with a can rule out most of the bone marrow metastasis. That's it.
Okay, sir. So we'll progress with the slides. So the patient was advised, since it was a non-metastatic presentation and a pelvic Ewing sarcoma, he was advised a neoadjuvant chemotherapy, which was a VAC-IE based chemotherapy. So next, I want to ask from the medical oncologist at our panel, how different is the VIDE strategy versus the VAC-IE strategy? And is there a lot of difference when you do an interval compression versus an increased dose density? Dr. Payal, any?
Okay. So, see, Ewing sarcoma is a systemic disease and it definitely warrants chemotherapy at the start, at the onset or upfront, whether it is localized, locally advanced or metastatic. For last few decades, the drugs have not been any different. It has been the permutation combination of VDC and IE. If you look at the American, the North American and the European group, the European group, what do they feel is that as IESS 2 study showed that the intensity of doxo is very, very important. So they try and exhaust their doxo during the induction. So they give wide, wherein they exhaust all the doxo during the induction, and then for consolidation, they give either VAC with VAI. Whereas the North American group, they give VDC-IE alternatively 3 weekly, and that is what we are also following. The interval compression, even for last 3 years, we have also started giving interval compression. That is, so the concept from where it came was that in ISS 2, it was shown that the intensity of doxorubicin is very important. So how do you increase the intensity? You could either do it by increasing the dose of doxorubicin, and making it more, you increase the doxorubicin dose, or you decrease the compression of the interval of the chemo. You could do it by 2 ways. So in INT 0154 study, what did they do? They tried to increase the dose of doxorubicin. Hello? And the standard arm, it received 3 weekly chemo with the standard dose of doxo, and the experimental arm, it received increased dose of doxo, and the whole regimen finished within 11 cycles. But this did not convert into a superior event-free survival. So then the COG in 2001 took up this study, which was interval compression, wherein they tried to decrease the interval between the two chemos and gave 14 cycles of chemo and increased the dose intensity by doing so. This definitely resulted in an 8 to 9% increase in event-free survival, as well as the overall survival. However, one thing which was interesting in this study was that it did not decrease the local recurrence rate. It only decreased the relapse at metastatic or combined local and metastatic. So we at our center are also practicing interval compressed chemotherapy for last 3 years. However, we are still to analyze our results.
Can we take opinion from Dr. Hazarika? Do you have a better take on a wide strategy rather than using a VAC-IE? Does it provide a better outcome when compared to VAC-IE? Or do you feel dose density is better to increase and give better control on local control when we compare to interval compression, which does not provide a local control benefit?
So I totally agree with Dr. Payal. Definitely this COG trial AEWS 0031, it has established the dose dense therapy, that is a 2 weekly VAC-IE with like GCSF support as the standard of care in localized Ewing sarcoma. And we also follow, in our institute, we also follow the same protocol. And yes, definitely, I'll go with Dr. Payal. Yes.
Okay, ma'am.
Dr. Himanshu, I think you wanted to know about the wide versus VAC,
Yeah,
the VDC-IE. So,
Yeah.
when as I said, the European people, they like to give a lot of doxo during induction, they give wide, and then during
So,
consolidation.
Dr. Payal, it is not about what European people like. It is about how better is the local control.
There is no difference. They could not establish
difference.
there was no survival advantage between the two groups by using wide or using VDC-IE. If that,
So both the strategies have a similar overall survival.
Overall survival as well as event-free survival.
Yeah, correct. Yeah.
The thing is the toxicity and the local control. Even local control was also, I think, same with the both the protocols.
Okay.
That's right.
So if someone is using a wide strategy, he's not doing an inferior treatment.
No.
Okay. Thank you. So we go back to the next slide. Okay. So this is a post NSCT MRI. Dr. Vivek, can you comment upon the response? Or is there contamination of the joint as well?
There is a complete regression of almost near complete regression of soft tissue associated with the lesion, but bony marrow signal alteration is still seen here. So it is suggestive of good response to therapy because soft tissue is complete near complete regression of the soft tissue component. I could not the lesion is involving the acetabulum, but no intra-articular clear-cut intra-articular extension is seen of the lesion.
Okay, sir. So next question is what I want to ask the nuclear medicine department here. The response evaluation post neoadjuvant chemotherapy. Is there a role? So do you feel a PET-based response evaluation offers a much better advantage when compared to MRI-based response evaluation? And how often do we do a response evaluation PET in our setting, Dr. Payal and Dr. Hazarika?
So, when as this is so if pertaining to this particular case, which is a
This particular case,
non-metastatic, yes. So this is a non-metastatic Ewing sarcoma. In all the non-metastatic Ewing sarcoma, in ideal setting, one can do a PET MRI and evaluate the local site as well as the metastatic site. But if we are not expecting at 12 weeks for the disease to progress and something which is non-metastatic to have something to have metastatic disease anywhere. So if we are doing only MRI, which in our hospital also we are practicing that in non-metastatic, we just do MRI based evaluation and not PET MR. As practice.
So Dr. Hazarika, we'll take your first opinion on this, whether you would advise an MRI-based response evaluation, which will only consider the local site, or a PET-based response evaluation, which can also restage the patient post neoadjuvant chemotherapy.
So if our initial investigation was PET CT, then after after NSCT, we evaluate PET only. But yes, in localized disease, MRI-based response evaluation is equally good. But what we follow is PET. Initially, if it is like if PET CT scan was not done, it was evaluated with MRI and CT scan, then we go for MRI based. But initially, if it was PET CT, then we go for like PET based response evaluation.
Okay, ma'am. So next question, I want to ask Dr. Akshay and Dr. Upasna.
Himanshu, can I come in for a second again before you ask the next question?
Yes, sir.
So basically, to answer the question again, which you have discussed with our medical oncologist, like wide versus VAC-IE regimen.
Yes.
So after the publication of the results of Euro-Ewing
Euro-Ewing,
2012, yeah,
wide is
so definitely that VAC-IE has shown a better EFS and almost a similar toxicity as compared to wide regimen.
Yes, sir.
So and that is what is being practiced at RGCI, I guess. So RGCI also use a VAC-IE regimen. So definitely, if you have to choose between the two regimens, because now we have a data which shows that a VAC-IE which is superior. So I will suggest using a VAC-IE over a wide, because that is where we have a data to support better EFS as well as a similar toxicity.
Yeah. So next question to Dr. Akshay and Dr. Upasna. So if we do a PET-based response evaluation or an MRI-based response evaluation, does it affect your local control strategy or adjuvant chemotherapy later?
Thanks, Himanshu. Answering the first question, whether we need to do a PET-based or MRI-based, I think if to start with patient had no disease anywhere else, I would be just as happy with an MRI-based evaluation, because it is in any case, an MRI will be required for local therapy planning. And at the same time, if we are seeing response locally, there is no reason to believe that he would have progressed systemically. So generally, if the patient did not have metastatic disease, then only MRI for me. If the patient had metastatic disease initially, then of course you would do a PET as well. Now coming to local control, of course, I would need an MRI in any case to decide and counsel the patient for surgery versus radiation. And an MRI would definitely be required. So it's either MRI alone or PET with MRI.
I think I agree with Dr. Akshay that if you're doing a response evaluation, even for radiation, we would definitely be needing an MR. Even if we are doing a PET, we would need for the planning process the MR. So MR is an absolute must. And once again, if we are seeing response at the local site, logically, we would not expect progression at the other sites. Based on that, we could proceed with a local MRI alone for response evaluation.
Okay. No, ma'am, it is about, okay. Next question is, sir, if you have a proximal femur Ewing sarcoma with a hugely grossly contamination of the joint, and you do a neoadjuvant chemotherapy, and a PET scan showed a very good response, MRI showed a very good response. So you would plan to do an intra-articular resection or an extra-articular resection if you have a proximal femur having sarcoma?
Okay, so we need to see whether the contamination was because of a surgical misadventure, or it was actually the disease entering the joint by way of its being locally aggressive. Yes. We also need to keep in mind one paper from TMH, which
yes,
said that there could be certain scenarios in well-selected patients where we can always be intra-articular. But given that it's an Ewing sarcoma and given the morbidity of an extra-articular hip resection, I would choose an intra-articular resection and adjuvant RT over an extra-articular resection anytime for Ewing's. So that question actually becomes more relevant for osteosarcs.
Okay, sir.
Manish, your point, your take on this?
So my take on this, like in Ewing sarcoma, there is no role of an intralesional surgery. Fine, you can do a marginal resection or you can do a wide resection, and marginal resection you can add radiation, but then there is no role of doing an intralesional surgery. So if there is a gross,
if the PET shows a very good response,
no,
and your
but
soft tissue component has receded.
No, Himanshu, it is not about the PET showing a response. It is that your joint was contaminated by the disease, your joint had a disease, then you are doing an intralesional surgery. The PET shows a very good response, then you don't need a surgery, because then you can think about the rest of the bone has also responded very well.
So but local control would not be given by the chemotherapy alone.
So that is what, no, then treat with definitive radiation, because the question here is whether you want to do partly excise the tumor and partly you are leaving the tumor.
So
you are doing an interlesion.
So proximal femur having sarcoma with little bit of extraosseous component, you would advise the patient for definitive RT?
No, Himanshu, if there is a joint contamination, I will do an extra articular dissection, because there is no indication of doing an like it is a similar scenario in the pelvis, like you have a iliac lesion going into the acetabulum, you leave the acetabular lesion and just do a iliac resection. There is some data actually has come on that also, that people have done a limited resection after but then they have used a protons in that, but they have done a limited resection. But currently that data is like do not have a very long follow-up. So currently, as of now, there is no indication of doing an intralesional surgery. Even if your joint is 100% contaminated, so I will do an extra articular.
So
if the joint is doubtful, I agree with the Akshay's point. Like it's a doubt, hai? If it is a doubt, then you can give a chance.
So there is a difference between gross disease inside the joint and some contamination that you expect having been done by a previous surgery, which sometimes happens. So that is where you need to make that difference in a well-selected patient.
Yeah. Many of the time we ignore a biopsy scars in Ewing because we cannot take that, and then we cover them in radiation. So those are different scenarios.
Similarly, a scenario where there is a pathological fracture in a long bone.
Yes, agree.
You resect,
totally agree,
but at the same time, you choose a non-biological method so that you can back it up with adjuvant RT, because you know there has been contamination.
Okay, sir. We'll go ahead with the presentation. So local control modality in this particular case, whether surgery or definitive RT, would ask Dr. Akshay and Dr. Manish on the comments for the surgery aspect, as well as Dr. Manoj and Dr. Upasna for the definitive RT aspect. Considering a pelvic acetabular lesion with or without possible intra-articular contamination.
So one, of course, we...
Yes, sir. Sir.
So one, of course, we need to see whether there is, so we need to see all imaging, whether there was actually intra-articular disease or not. And that will also change a little. But at the same time, as you would always do for a pelvic Ewings, you sit down with the patient, you maybe counsel them not once, but all through the NACT, one at the initial presentation, and then maybe a couple of sessions during chemotherapy. That you may have a better local control with surgery and radiation as compared to RT, but you don't have a definite evidence that surgery will give a survival advantage to this patient.
So your choice in this particular case?
My choice will be surgery with RT.
Surgery with RT?
Yeah.
Dr. Manish? Yeah.
Himanshu, I totally agree with Dr. Akshay here. Like in this case, definitely the patient requires a radiation therapy, whether you give a preoperative radiation or an adjuvant RT or a definitive RT. The radiation has to be given in this because of a large volume of a disease and inability to get a very wide margins. But yes, surgery plus adjuvant RTS, Dr. Laskar has shown definitely improves our local control rate as compared to only radiation.
So
So in
why
this
not a
case, the
dose
choice,
escalation definitive RT?
sorry.
Dose escalation definitive RT.
So as Sir has also said, Dr. Laskar, that the data is not published, we can try a dose escalation RT, but for a resectable E-wings, currently the standard of treatment is surgery. And when your margins are down or when you have a large volume of disease or you have some contamination, then definitely a radiation should be used as a backup. So we should add a radiation there. So in this case, the best plan I think will be doing a surgical resection followed by adding a radiation.
Any difference of opinion from Dr. Upasna and Dr. Manoj in favor of definitive RT?
Not exactly. Yeah.
So you can
not exactly difference of opinion, but yes, if you look at the location of the tumor and if you want to maintain a good functioning of for the patient, even definitive radiation is a good option because doing only radiation or doing radiation after surgery or before surgery and adding surgery, it may not be adding on to the overall survival of the patient. So yes, if surgery happens, it gives a better local control, but it doesn't add on to the overall survival.
So, but if you have a locally recurrent Ewings for a scenario, it has a much worse overall survival as compared to a distant relapse Ewing.
That the time only will tell.
So that's the data which is there.
Himanshu, in this case, acetabulum is already involved. So you have to compromise the hip joint also during the time of surgery.
Yes.
Sir,
So I think what is
Himanshu,
what is what is important here is that the patient knows everything that you do, right? The patient has to know the kind of function he's going to end up with after surgery. And as Dr. Manoj said, definitive RT definitely gives a functional advantage. And it's not as if none of the patients with definitive RT will get cured. So it's very important that you have a few counseling sessions and only then take that call.
So the panel decision would be first priority to surgery plus adjuvant RT followed by definitive RT if the patient chooses for some functional benefit rather than overall survival benefit.
Dr. Himanshu, I'd like to say that yes, both the factors do come into picture. We do have a better control if we do a surgery with radiation. But once again, the decision has to be based on a proper discussion with the patient. Now here, because if we are choosing definitive radiation at his age, we need not worry about any skeletal growth abnormalities. So the functional loss has to be in detail discussed with the patient. So I think that would also be an important part of the decision process.
I agree to this because definitive RT. If you look at the indications for definitive RT, it is generally we say that the location of the tumor and the operability of the tumor. So if you look at the location of this tumor and if you look at the age of this patient, obviously functional outcome is very important for this patient. So I think the patient should be completely aware of before he decides for surgery in a scenario like this.
Okay, Manchu, you have 3 minutes.
3 minutes, sir. I'll just proceed faster than sir. So this is what was treated in terms of local treatment, a definitive RT, external beam radiotherapy to pelvis in dose of 55 grays. So we go ahead with the adjuvant therapy, which was a VAC-IE based chemotherapy. Let us just take opinion from Dr. Hazarika in terms of concurrent CT-RT when you've chosen definitive radiotherapy for a patient.
Yes, there is definitely a role of concurrent CT-RT, considering it's a systemic disease.
But do you change the dosage of adriamycin?
Yes, and we don't use actinomycin D if it is a like head and neck tumor, and of course in pelvis we use, and definitely concurrent chemotherapy we definitely use it.
Does that reduce the overall survival if you change the dosage of the chemotherapy drugs?
So for concurrent chemotherapy, those I don't know. I don't know of any like literature whether there is um, prognosis. There is change in the outcome.
Okay.
Uh, um, but because of the toxicity, when we use definitive RT, because of the toxicity, definitely we don't use the more merotoxic drugs along with RT.
Okay, ma'am. So is there also a role of changing drugs if you have a good pathological response available? Or if in case of definitive RT, you don't have a pathological response to assess and you decide on the basis of PET scan, which was done pre-operatively? I don't think so. There would be a lot of difference of opinion in this. I don't think so that changing chemotherapy drugs would be advisable.
Yes, definitely. Of course, this group of patients who fail to respond to the initial treatment, NSCT, they have definitely poorer outcome. But yes, there is no role of change of drugs.
Okay, ma'am. So we'll go on to the next slide. This is a post-treatment PET after completion of chemotherapy, which showed significant response to treatment with residual bony abnormality as described, which was post-treatment changes, I think. So I want to ask to the radiation oncologist or Dr. Payal, is there a recommendation for post-treatment PET always? Or is there also a recommendation of a follow-up PET scans in an Ewing sarcoma, which is post-treatment?
So post definitive radiation, we would definitely need PET for evaluation.
Correct. I
to
agree
the
to
approach.
that.
Okay.
Yes, so
Because it
definitive
is not only the local site, it is not only the local site, you have to look at the systemic sites as well, like the lungs and the bones.
Okay, sir. So the timing of these PETs would be 6 monthly?
3 monthly to begin with.
Every 3 months
First
a
PET
PET
at 3 months. Yeah, first PET at 3 months.
So, Dr. Himanshu, if I
Himanshu,
can come in again.
yeah.
Yes.
Yeah. So we have a
So
data from TMH. Sorry, who is speaking here?
No, please go ahead.
Please, Dr. Akshay, go ahead.
So what I was wanting to say, I think you're going to make the same point. We need to see what change in the outcome or further management or follow-up imaging is going to make. Right. So I don't know of any definite evidence that serial PET scans are going to change the course. And in our setting, usually a CT chest and a local imaging is what is done for follow-up of Ewing sarcoma. And if there is some symptom anywhere else, only then we go for a PET scan. But I'm not denying that getting a PET scan is also is okay. But if we want a message to go to the participants, I think a chest and local imaging would be just as good.
Okay, sir.
Also, the amount of radiation exposure that is going to happen in this pediatric patient by doing a 3 monthly PET scan is also going to be huge.
Huge.
Agree.
And also, some patients may actually require sedation for doing. So I think it is going to be a Herculean task to do it, and also radiation exposure that has to be kept in mind.
So just to add on to what Dr. Akshay said, Himanshu, there's a data from Tata Memorial Hospital, which was actually a randomized controlled trial, which is a TOS trial for optimal surveillance of sarcoma patients, in which we have compared actually 3 monthly versus 6 monthly follow-up and doing a minimal imaging, which is an imaging plain radiograph of the chest and the local site versus an intensive imaging, which is a CT scan of the chest as well as the local imaging. And actually we found no difference in the survival. There is no survival advantage which intensive regimen with an intensive investigations gives.
Okay, sir.
So per se, what we are following currently is a 6 monthly evaluation and doing only a local examination, a local X-ray as well as the chest X-ray. If we find any doubtful lesion, then only we ask for a further cross-sectional imaging. We did not find any significant improvement in outcome by detecting a recurrence early.
Okay, sir. So we'll proceed with the time. There was a PSI of 5 years, and following 5 years, the patients in 2018 complained of pain and swelling at the local site. So we did an MRI. This was the MRI. Dr. Vivek, I wanted to ask you, how do you differentiate on an MRI in terms of recurrence versus a post-RT change? Are there any obvious differentiating features on MRI? Or do you always want a complementary PET investigation? I think Dr.
Yeah,
Vivek.
in this post treatment MRI, we always recommend doing contrast enhanced MRI to look for any recurrence. If there is any new appearance of soft tissue, like here I can see, though it is not a contrast imaging, I can see some soft tissue at the medial aspect of the iliac bone. In this case also, in the soft tissue is seen in the iliopectineal region.
Yes, sir.
So then it is suggestive of some recurrence of the disease, because new soft tissue is seen now.
Okay, sir.
After
So
5 years.
would you advise a PET also along with it, or a contrast enhanced MRI is enough?
For the local site, the contrast enhanced MRI is sufficient.
Okay.
But if you want to look for any metastatic disease, then you have to do PET-CT.
So this was the MRI which showed a metabolically active acetabular lesion and no other metabolic disease elsewhere. A CT guided biopsy confirmation was done, which was suggestive of a recurrence in a known case of Ewing sarcoma. So now my next question is to the panel is, what further treatment plan would you offer to the patient? Whether these 5 options are there: a second line chemotherapy followed by surgery followed by completion chemotherapy, second line chemotherapy versus re-irradiation followed by completion chemotherapy, and upfront surgery followed by adjuvant chemo, re-irradiation versus plus chemo, or best supportive care in a locally recurrent Ewing's DFI of 5 years. So Dr. Payal and Dr. Hazarika, in terms of medical oncology aspect.
Yeah, so definitely we are not doing surgery upfront and we are not radiating the patient upfront. And we would like to go ahead with second line chemotherapy. And we've got, there are no standardized regimens per se for relapsed Ewing sarcoma. And we have to understand and discuss with the family that the outcome is not very fantastic. The regimens which are available, I would say the most famous or the most popular ones being cyclotopo. Then you've got gemcitabine docetaxel. Then you've got high dose ifosfamide. You've got irinotecan and temozolomide. And there is this record trial which has happened, the record trial which has compared the salvage chemo regimens and has shown that gemcitabine docetaxel and the temozolomide with irinotecan have had an inferior survival when it is compared to cyclotopo and high dose ifosfamide. So probably.
Yes, ma'am. Dr. Akshay and Dr. Manish, why not upfront surgery and adjuvant chemo?
So number one, the outcome is not going to be great. Ewings with a local recurrence generally will not make it. So that we need to know. And we need to know whether the patient is responding to a second line chemo or not. Because then you'll be able to pick a patient for local therapy. I'm not saying surgery here, local therapy.
Yeah, but in an already definitive radiated field, does a second line of chemotherapy show a good amount of response in the local site, because there is no systemic elsewhere disease to assess the response?
So you need to see, you need to pick up the right. So number one, I would agree that second line chemo is not out of place.
Yes.
Because the disease-free interval is 5 years. But at the same time, you need, again, it's going to, a recurrent Ewing's is just as systemic a disease as a primary Ewing's.
Okay.
So you need to always start with systemic treatment. You need to pick the right patient for an aggressive treatment versus someone on who's going to go for best supportive care. Suppose a patient progresses on second line chemotherapy, then you need to seriously, you need to seriously discuss best supportive care with him.
Okay, sir. So we go on to the next slide. Patient was chosen for a salvage cyclotopo cycles of 3 cycles of neoadjuvant. Post 3 cycle salvage chemotherapy, this was the MRI, which did not show any significant difference in the soft tissue component on the medial aspect. So now my next question is, post 3 salvage chemotherapy cycles, there is no obvious progression. So now what local modality control you'll choose? A definitive RT or a surgery in terms of internal hemi or an external hemipelvectomy? So let's just take opinion from the radiation team first. Whether definitively
I will advise for to go for surgery only, because re-radiation, if you're looking at a definitive dose, so I think will be giving more morbidity. But yes, definitely go for surgery, and then based upon the histopath report, based upon margin status, I will advise for adjuvant RT.
Adjuvant RT, surgery plus adjuvant RT. So Dr. Akshay sir, whether internal or an external hemi?
Well, I'll need more imaging and more counseling to decide on that.
Okay, sir.
Going by this MRI, internal seems okay, but then patient having received a full dose RT is going to make surgery hell. So we need to understand also that.
Okay,
so
sir.
internal versus external, whatever. And maybe if it's external, then of course radiation will not be required. If it's internal, then adjuvant RT might still be considered.
So in terms of local control, would internal be an inferior choice in a previously radiated field?
Well, it's more about the ease of surgery. Number one, you will not find planes extreme fibrosis. You'll not be able to differentiate between fibrosis and disease. So these are the main problems.
Okay.
So
Per
Dr.
se-
Pal, I hear that patient had received only around 56 gray. That also was 5 years back. So I think 56 gray should not have that much of a fibrosis as compared to patient receiving 70 gray. So you can still give a benefit of doubt to this patient.
Per se, Himanshu, like before Payal speaks, sorry Payal. So per se, Himanshu, the internal versus external decision here, as Dr. Akshay has pointed, is based basically on the relation of the vessels and the status of the tumor to the neurovascular bundle. Basically, because here now, even if you do an external hemipelvectomy, your margins remains the same because the disease is in the acetabulum. In the acetabular area, the periacetabular area, even you do an external, your margins remains the same as with the internal because the disease now is not extending beyond the bone much. So I don't think you can change your margins based on external or internal, and the decision mainly depends upon whether you can safely do an internal hemipelvectomy. And I think that was the call taken in this case.
Dr. Himanshu, we are having a great discussion, but we are overshooting the time grossly.
Give me just 2 minutes. I'll finish, wrap it up.
Yes, sir.
Okay. So this was the local control strategy which was adopted, internal hemipelvectomy with a meshplasty. And this final histopathology was residual tumor in a known case of Ewing sarcoma with residual tumor of viable of 20%. Is there a role of post-operative radiotherapy in a negative margin surgical resection in an Ewing sarcoma? Does it improve local control is my important question, which I wanted to ask to the panel.
So margin negative, I think, for margin negative, there is no role of, port. So you can just go ahead with your adjuvant chemo.
Sir, but when we are not sure about the margins with a high volume disease, but histopathology says it is negative.
It was only at 20% residual and the margins are all clear. And
so no role of
an
radiation.
internal hemipelvectomy is already done. Yeah.
Okay. So adjuvant therapy, salvage chemotherapy again, is there a difference in putting the patient now to a high dose chemotherapy and stem cell transplant, whether following a routine salvage cyclotopo or a high dose chemotherapy and stem cell transplant for a better overall survival? Dr. Payal or Dr. Hazarika?
Actually, there is no standard treatment, no standard protocol. So some studies have shown most of which are retrospective studies, they have suggested improved outcome with high dose chemotherapy with autologous stem cell transplantation in recurrent Ewing sarcoma, but no prospective randomized control trial is available till date, and also it is very difficult to identify a suitable control population so to interpret the results. So it is not a standard practice as of now. In addition, the another problem is that patient must remain progression free until the high dose CT is administered, and must have adequate stem cell collected, and also there should not be any comorbidity. So it is a job now, it is not a standard protocol.
So we'll proceed with the case. There was a DFI of again 20 months, which is 1.5 years. Patient again came back in March 2020 complaining of recurrence of pain and swelling at the local site. This was the MRI with a huge soft tissue recurrence in the operative field. So my next question, PET we did, it was still non-metastatic locally recurrent Ewings. Treatment plan further. Third line chemo, surgery, completion chemo, third line chemo, re-radiation, completion chemo, upfront surgery, adjuvant chemo, role of RT.
Option 5.
5? There is no systemic mets.
Still option 5, sir.
Any difference, Dr.
We can consider the patient assessing the disease. I mean, we've just seen one slide. We can consider the complete imaging and consider for a re-irradiation, either a conventional
why not?
or a
Why not?
stereotactic, depending on the bone involvement, because that would not cause a lot of morbidity. But yes, it would help control the disease.
So now
even in the adjuvant setting at the first recurrence, if the necrosis was not good enough, we could have considered adjuvant radiation. If the necrosis was less than 90% tubal response, we can consider, because 5 years is a good enough duration. At this point in time, definitely using a local radiation, depending on the disease, choosing the type of radiation would do benefit to the patient.
Then my question is whether to give only radiation or chemotherapy third line followed by radiation. So option 4 you choose or option second you choose?
But depends on the condition of the patient, whether the patient is in a position to tolerate, and that choice I think I would leave to the medical oncologists.
I'll go for third
Medical
line chemo
oncologist is
followed by
not
local
ready
treatment.
to give chemo.
Yeah, I'll go for systemic therapy followed by local treatment. Local
You've
treatment
already
with surgery
exhausted
if
all the
possible.
systemic chemotherapy drugs which you have.
I mean, if the patient had already exhausted, but this is just a second recurrence, so he has not yet received many other drugs which are available.
But they are not as good as the first line or the second lines.
So the medical oncologist has already raised his hand. So yeah, then it's all palliative treatment. If you do re-radiation also, we can give only pain relief and maybe.
But then that was the only chance that we had. So post-op RT then probably could have been discussed. Now I think at least palliative RT, if not anything else, because he has pain. And then of course,
Dr. Akshay. Yes, post-op RT is indicated when necrosis is less than 90%, even if the margins are negative, as recommended by your National Cancer Grid also. So post-op RT could have been discussed. But yes, now the intent is definitely palliative and it's a candidate for clinical trial now.
But yes, that's one more thing, clinical trial definitely to take for a high dose. I mean, whether any other agents or the immunotherapy. But I wouldn't say without assessing the complete imaging that the radiation dose would have to be palliative. We could attempt a dose with a radical intent as well. Definitely without systemic, it would not lead to a very long-term control. But yes, we should assess with an open mind and not consider only a palliative RT dose based on the current imaging. We need to assess that.
My question to the panel is what basis we decide this is palliative?
Himanshu, we need to conclude, I guess. Okay. Dr. Jaskaran is getting restless. We need to conclude the session. Just final comments, I guess.
This patient was next lost to follow up to us. So we don't know the present status of the patient.
We've concluded, sir.
Yes, sir.
Thank you.
So thank you, everyone. Thank you, Manish, sir. Thank you, all the panelists, for a very interactive session, I would say. And now I would hand over to Dr. Jaskaran for vote of thanks and concluding remarks.
It was a great webinar, I must say. We had very nice discussions, and I'm very thankful to the whole faculty for bringing in their expertise and discussing issues which we face daily in our practice. And many questions have been answered today, I hope, for most of us. At the same time, I'd like to thank the management of Rajiv Gandhi Cancer Institute for having given us the opportunity to have the webinar, the leadership of AROI for extending their helping hand. And I would also take this podium to thank my fellow colleagues in the Department of Pediatric Medical Oncology and Surgical Oncology and Director for Radiation Oncology, Dr. Munish Gairola, for having extended all their support in conceptualizing this program and making it successful. And last not the least, big thanks to our marketing team for giving us a good organizing atmosphere, and Mice Ideas for hosting us on the web. With that, I would like to end the session. And I hope that everybody enjoyed it, and maybe we can do something like this on an annual basis or more frequently, because I think people who are involved from radiation side in pediatric care have a lot of difficulty in managing these patients, and the multidisciplinary approach which we are blessed to have at good institutes is what needs to be replicated all throughout India. Thank you very much for being a part of the webinar.
Thank you. Excellent program. I think this was a great initiative by the radiation team at Rajiv Gandhi. Dr. Jaskaran and Dr. Anjali, you've done a wonderful job. And I think it has increased awareness about, recent advances in pediatric solid tumors. And really, once again, thanking AROI for allowing us this platform to have this update on pediatric solid tumors. Thank you so much. Excellent.
Thank you, Madam. And we can conclude. Thank you so much.
Thank you.